Per i relatori connessi da remoto, penso che mi sentiate. Sì, vedo il cenno con la testa di entrambi. Perfetto, grazie. Tanto abbiamo già fatto una prova con l'assistente di Fausto e insomma abbiamo visto che funziona l'audio e tutto a posto. Quindi a più tardi. Per qualsiasi comunicazione possiamo scrivere in chat.
Good. Is this working? Allora, cominciamo in italiano. Benvenuti tutti. Benvenuti. Funziona questo o no? Is it working? Maybe we don't need it. Sì? I'm not sure that's... Yes, it is. Funziona. Allora, benvenuti tutti voi alla residenza britannica questo pomeriggio. Cambio subito della lingua di Dante nella lingua di Shakespeare, so we can continue in English if that's all right. But welcome to all of you to the British residence here at the heart of Rome this afternoon to discuss such an important topic. And the fact that we're able to hold this meeting in this way, in presenza here, is itself a sign of how far we've all come in the last year, in the last couple of years. And a lot of that, of course, is thanks to your efforts and the efforts of your colleagues in both our countries and around the world. But both our countries, as with the rest of Europe, as indeed with the rest of the world, have been through so much in the last last 3 years. An experience none of us, well, many of you did imagine it, alas, and you that we all knew this was a possibility. But those images from northern Italy at the beginning of 2020 and what we saw happening there, I don't think any of us will ever forget that. And whenever I go to northern Italy, I'm very struck by the lasting impact it's had there, but also of the resilience and strength of the people in overcoming those terrible challenges. In the last few years, our countries have worked incredibly closely together. You as professionals have worked so closely together, and I'm so pleased that we're able to welcome you here today, particularly to welcome Susan Hopkins here today. Thank you for making the journey, and so many of your colleagues as well as our Italian colleagues, Professor Ippolito, dove è? Lì. Buonasera, grazie di essere qui insieme con noi questo pomeriggio. And also from our colleagues from the international organizations based here in Rome. I don't want to bang on because we really need to hear from you, the experts, but the purpose of today is to share what we've learned, but above all, to share our views and experience and learning on preparing for the future and making sure that next time a pandemic comes along, as surely it will, hopefully later rather than sooner, that we are more ready than we were last time and that we don't forget what we've learned over recent years. So a big thank you to all of you, and a big thank you to my own team at the Embassy, from our Science and Innovation team, for putting together this event. Thank you, and I'll passo la parola a Susan Hopkins.
Good afternoon. I'm not going to attempt to speak Italian, but I am delighted to be here with you today. Just waiting for some slides to come up. While they're coming up, my name is Susan Hopkins. I am the Chief Medical Advisor at the UK Health Security Agency, an agency formed out of the pandemic, and I'll tell you a little bit more about that. We work locally, regionally, nationally and globally to fight infectious diseases threats and other external health threats such as chemical, radiations and environments. By background, I'm an infectious diseases clinician, and Silvio's not here, but I've known him for more than 20 years working on infectious diseases across Europe. And I think the living and working through a pandemic has been a life-changing experience for many of us who have worked for infectious diseases. So, waiting for some slides. Well, I'll keep talking and we could just skip through them as we go. So our mission as an organization is to ensure that we're able to deliver operational brilliance to protect us from the... That's the last one. The second last one. Move this to the second one, that'd be great. To allow us to tackle our known threats. No, that's... to tackle both known threats and reduce their impact on human health, but even more so to be agile and responsive to tackle new and emerging threats, threats we don't yet know of, threats that we're not sure how to respond to, threats that we are unsure at what our diagnostic test will do, threats that we have no vaccine for. And that, I think, is where we've all learned a huge amount over the last 3 years and where we need to focus our efforts. And my vision is that we live in a world where public health institutes, governments, academia and industry work collaboratively to identify and respond early and effectively to new threats so that it allows zero impact on human lives and livelihoods. And I think that's not going to be something that any one of us individually can do. And it's going to need funding, a collaboration, and a great understanding in moving how our health sciences work but also working very closely with the wider institutes of government and with the wider institutes of global health as well. We're back on track. So we've just celebrated our first birthday. It's the new organisation, UK Health Security Agency. And in that short year, we've responded to variants, notably Omicron, and of course we're now on multiple descendants of Omicron, each of those with their own challenges. But we've also managed cases of imported Lassa fever with a household transmission, but prevented that case transmitting further in the healthcare environment and to the community. We were the first country in the world to identify monkeypox in men who have sex with men, and that was a really important landmark for us because it allowed us to rapidly share those findings with other countries. We detected the case on Sunday night, and we informed World Health Organization on Monday, and informed colleagues in Portugal on Sunday night, as they had previously, through the European alerting system, said that they had unusual cases of rashes in men who had sex with men. So informing them of that made sure that they were able to rapidly go back and test those individuals. And I think the global efforts and global communications that we've made have meant that we've had a vaccine, utilised a vaccine that was there for smallpox. We've started to understand the genomics. We've rapidly shared our understanding on diagnostic tests. And all of that has meant that it has allowed us to reduce the burden of that disease. In England, we've got, let's say, at our peak, very close to 100 cases a day to now less than 10 cases per day. And through genome sequencing, and we've got Sahir Arbia here who leads this work for us in gastrointestinal infections, we were able to identify a salmonella cluster of infections, particularly happening in young children, and we're able to identify the source as Kinder eggs and be able to remove them from the market just before Easter. I'm not sure children or the company were happy, but at least we were able to save some lives. And over our extended wastewater detection using whole genome sequencing, we were able to identify polio in the wastewater and vaccine-derived poliovirus in the wastewater, and start a campaign of information sharing, vaccinating our young people, boosting their vaccine. And with all of that work, we now are no longer detecting it in wastewater, and in addition have not had a clinical case of polio disease. So those are successes, and we need to build on those successes from our first year to ensure that we go further and are ready for the next threat. And we're used to threats. This is our sort of threat landscape that we've faced down in the last 15 years. But I think that if we look at that, we can see in a variety of different things. We've got chemical and radiation hazards, as well as the environment with floods. We had a major fire in a London apartment block due to the surface of the building. We've had a Novichok poisoning, and then we've had emergence of detections of diseases such as Zika and MERS, and of course COVID-19. Here also highlights the importance of working with animal and environmental health partners to tackle world problems that are emerging and causing more problems, such as hepatitis E, often transmitted through food or food products, and avian influenza, which is now sweeping across Europe with numbers of cases like we had never seen before. We've just done our first human risk assessment on this and looking at how and where that might affect us in the longer term. And I think the important things to highlight there is that with the more cases that we're seeing, particularly in poultry and farmed animals, means that there's much greater likelihood of exposure to humans, much more greater likelihood of acquisition to humans, and therefore the likelihood of changes and adaptations to allow it to transmit from human to human. We cannot take our eye off the ball. All of this means that One Health is even more important than ever to tackle everything from infectious diseases to risks associated with climate change, biological threats, and wider dangers. I know you in Italy have had a difficult summer with increasing heat, and we in the UK are very conscious that as the temperature rises, we will have an increasing number of viral vectors or mosquito-borne vectors come in that may transmit disease. And I again think that the work we do together in Europe and globally to understand those vectors and how they are moving across Europe will be essential for new diseases. what about learning? So learning from the pandemic, I've compressed it into one slide. I could actually talk all day. We've learned a huge amount in the pandemic. The first, I think, is the rapid detection of novel and emerging pathogens. How fast we do that, how fast we share that information will be critically important in developing diagnostics of vaccines. The sharing of that genome in January allowed vaccines to start to be manufactured and allowed diagnostics to start to be delivered and to finesse those diagnostics. But we need to have a very low threshold to identify new threats. We need to share that information widely. And we need to use the technologies that we now have available to us through much wider use of genome sequencing to help us. I, as a clinician and epidemiologist, I'm very keen that we have very good characterization pathways for understanding the clinical disease, the severity, who it affects, how it transmits, and the impact on the population. Because that allows us to get proportional measures in place to protect the right people as fast as possible. Of course, without understanding those characteristics of those populations, we won't necessarily administer the right countermeasures, the right support to individuals. We've learned a lot, I think, as well over the last couple of years about monitoring and surveillance. What do we need to do to understand and improve our knowledge? I think in the UK, we learned a lot about having community infection surveys, something that we did not do routinely before, where we surveyed healthy individuals in the population and determined what symptoms they had and the proportion of those individuals who had asymptomatic and symptomatic disease. That did two things that we really were blind to at the start. It allowed to understand the infection fatality ratio, how many people were dying from having an infection, and the infection hospitalization ratio, to understand the impact this was going to have on hospitals. We need to be better and more fluid and agile in doing these studies earlier so that we can predict the impact in a wider way. And of course, when it's very early in the disease, those are quite difficult because there will be very small amounts of infection out there, so you'll need a very large survey to detect that. But you can work with particular populations or sampling frames, as we call it in epidemiology, to look at those populations who are at the highest risk, particularly returning travellers from overseas, particularly those who are in the 20 to 30-year-old age group where infections often circulate without harm. And I think we would all recognise now, looking back, that this infection was circulating in our young, healthy population for some time before we saw the impact in the hospitals. I'm also very keen on highlighting the risks of non-pharmaceutical and the risks of not investing in non-pharmaceutical interventions. We have a lot of talk about diagnostics. We've got a lot of talk about therapeutics and vaccines. They are extremely important and our way out. And even though we have many of us in G7 and G20 countries have committed to the 100 days mission in getting diagnostics, vaccines and therapeutics better and faster, for at least the first period of time we will need better non-pharmaceutical interventions. Some of you are wearing masks in the room. That was a very good intervention, but it was slow to come in and slow to transmit across the population. Easy for the virus to transmit, less easy for good behaviours. Other aspects may be equally important, and I think the amount of funding that was given to understand and develop evidence for non-pharmaceutical interventions was less than 5% of the total funding for intervention trials. That's something that I feel quite passionate about in the long-term interest in infection control. Clearly collaboration, and I put collaboration at three levels: population, professional and partners. So at a population level, we need to be able to have open conversations with the people that live in our countries. We need to think about what we can do in peacetime, that they are ready for the interventions we might need to deliver in a pandemic or in an emerging infection, so that it doesn't come as a shock. While people will now remember these events, they may already be thinking we didn't need to lock down. It was not necessary. We could have stopped it. And actually we need to explain to them that these are interventions that are there to allow people to live, to keep our population healthy, whilst getting and waiting for countermeasures. And then once we have countermeasures and once we deliver those effectively to the population, we should be strong about removing those restrictions on our lives. And finally, I would mention health inequality. In our country, the people who are the poorest, the people who lived in the most deprived areas of the country, the people from ethnic minorities, the people with the most health conditions, the oldest in our population were the most affected. We need to tackle health inequalities all the time if we want to make a difference in the pandemic. And that means good housing, good jobs, good living, good health. And that's going to be really important for us in the future. So what does that mean for us, and why would we like to be a partner? So us as an agency, we have scientific excellence. We lead nationally and internationally on many projects. We work on developing diagnostics, developing genomics, countermeasures, training and research. We have great strengths in data analysis and surveillance that have been amplified during the pandemic, and we bring to that looking at all hazards in a holistic way. We have improved our operational agility and flexibility, and we are able to now operationalize testing and tracing at much larger scales and volumes than I would have imagined 3 years ago. We are a system leader. We forge partnerships with our wider health system, academia and industry in our country and globally. And it's a great opportunity here today to talk to many about that. We maximise the social and economic impact of health security. And because we work from within government, our organisation is part of government, we are therefore really critical partners with our government partners for funding, for recognising where the research agenda is, and then how we can move that forward. We have three key aspects that are our cornerstones for what we plan to do for the next 5 years. Prepare, prepare, prepare. Consider how we're ready to respond in a variety of threats. And so while we think about what has just gone past us, I think what is most important is to think about the diversity of things to come. Many of us will have talked a lot about pandemics. I think the vast majority of us believe that respiratory infections are the ones that are most likely to transmit the most widely with the highest R0 that we've seen. But it's important that we allow and consider other threats such as sexually transmitted infections, monkeypox we've just seen. But the largest pandemic in my lifetime that's caused the most harm has been the HIV/AIDS pandemic. And so we must be able to be flexible to look at a variety of different threats and work with different communities. And finally, to build not just for ourselves but within the country, the capacity for a diagnostics industry, a vaccines industry, and a pharmaceutical industry, so that we are not so reliant on other countries, but that in doing that we can work with other countries on a partnership basis. We're a global public health system. There are lots of partners and players. And I don't expect you to read all of these here, but this is what we believe are our core partners globally, nationally, regionally and locally. And today's meeting provides us an opportunity to draw on the British and Italian experiences during the pandemic, allow us to reflect on how we exchange views and best practice in preparing for and responding to global health threats. In particular, considering our joint relationships, allowing us to work on the global health security agenda, and thinking about how we develop partnerships with the academics that are here as well as the public health institutes. I'm extremely grateful for all of the input the National Institute for Health in Italy and the Istituto Superiore di Sante shared with us in those very early months of the pandemic. I know that not only people in this room, but clinicians in the hospital and national centres of excellence got on the phone day and night when they were already working flat out to share their experiences and give us pointing. We're very thankful and we hope that can continue.
Thanks very much, Susan. And I now introduce Professor Giuseppe Ippolito from the Italian Ministry of Health, Director of the Research.
Good afternoon. Thanks to the Ambassador and thanks for this kind invitation. Waiting for the slides. Italy was really a case study since it was the first affected country in the Western context, and we had tremendous experience with lack of preparedness that terms of lack of preparedness, we have several information from previous outbreak, and before the Brexit there was strong collaboration in the field of active preparedness, and this is continued also after with UK institutions. But what is important in terms of management of the activity is the not able to some figures about the model that we use in our framework, in a general framework of okay. No, this no this. Vado avanti. Ok. Ancora? So if you have a look at the map of the northern Italy, how this affected, it's clear that the preparedness for were not possible preparedness to deal with this emergency. La prossima? But of course Italy invested in the past year a lot of the time to prepare. La prossima. The main problem was common with other countries, that was they needed to take decision without data, without clear with the need to manage the problem with the experts, but not experts are exactly the same, with lack of manual for management of outbreak everywhere in the world were not full, not booked enough, and the risk is evolved across the months and across the update of the destinations. So we need a rapid, coherent process for addressing scientific issue in the middle of crisis. This is not new, but it's a sentence of Michael Meyer 20 years ago, and is common to decision in critical situation. Before of the pandemic, we already defined some problem, some requirement to manage the situation in terms of food, energy, and medication, to try to evolve in independence of the country, involving infrastructure, first of all, surge capacity, emergency response, and management of social communication, with management of data and information on vaccine and medical countermeasures. And this also is an old slide, is a slide of 1996 by Tony Fauci. Next. And what about decision about the restriction of mode? This was another critical issue to manage. And we know that spread of infectious disease was in the Global Economic Forum the first of main area main area to deal in this context. Since from economical point of view, economic disruption after an epidemic was considered so relevant and requiring immediate answer. But this is another model, this 204 WHO recommendation for gaps, for insufficient public health capacity to respond to the emergency, for lack of well-documented research. The word well-documented research on the mechanism of decision making. Maybe that we have excellent scientific research, excellent basic research, but no one until now considered the need of research on the mechanism of decision making, need of analysis of the field since the countries are not exactly the same. The vertical, we are a country with 20 different regions. UK has one single decision criteria for decision making. We need the detailed international comparison between public health and the implementation of the activity using networks and the mechanism. All the networks and mechanisms established before have been not enough to manage the situation at international level, and we have a decentralization with the pluralities that was a problem, is a problem now, but was a problem also in 2004 associated with the weakness of public health infrastructure. So we have to consider this as a possibility for the future, and in 2009 in the Global Health Security Index, no country appeared to be fully prepared for a catastrophic biological events. And during the summit in Dubai, where we attended with Sergio a few months ago, the Tedros Ghebreyesus report that we know that we will have another pandemic in short time, and we are really convinced that we must try rearrange our activity, since we must try to have a lesson from this pandemic. Few months ago, the problem of polio reopened as reported in UK and after monkeypox. We must be ready, but we have a stable problem with antimicrobial resistance that must be considered as one of the major problems in the management of the situation. During the analysis of the risk this year by Global Economic Forum, the scares of HIV were first determinant of economic management in different contexts, since there are three main risks about this, the societal, organizational, economic, and the risk of lack of attention to the problem. So three main risks that affect, and we consider infectious disease now ranked sixth in the priority of for the next 10 years. When this is split by year, we consider that the risk for infectious disease is considered a maximum in the next 2 years. But in the analysis discussed during the World Economic Forum, we have two problems. First, the need of governments that must be ready to adjust the response, and the second, the ability to maintain compliance with the decision making. This is one of the problems between science advice in the pandemic that has been largely discussed. 1 year ago, we prepared in Italy this document for the international academies. You know that for the G20, the Accademia dei Lincei was in charge to prepare the draft, and now we are in the phase to rearrange and re-update this draft. This is the basis of the final joint statement with the perspective for detecting unusual cluster, for global alert and response, for policy and the platform to share some data, and pathogen genomics. Pathogen genomics has been also the key area of debate at WHO and meeting in Bellagio in mid-April to define common criteria and common strategy for genomic surveillance, but also the investment in research on genomic pathogens. Italy performed very well at EU level in terms of research, thanks to the money of the European Commission, with a lot of money arriving in Italy to promote research, most to create models and simulation at computer with and the model spread by the physicists. Physicists were able to take more of the call, and molecular epidemiology surveillance for all the respiratory infections. This is the key topic for managing the future, but we need research on the molecular epidemiology. We don't need single spot collection of data. We need a continuous way, like in 67 years has been performed for influenza. Only a model that is parallel to the historical model of influenza could be useful and build capacity for support in the strengthening of the system. The second bullet of the joint statement was increased technology for manufacturing capability worldwide. That is exactly the same that was reported in 1996 when support the production of autonomous activity, define a new regulatory process, implemented in a very short time. 2 days ago we do an exercise with post-TOEFL for that are a lot of experience in vaccine and now is moving in nanomolecules and genetics therapies with the idea to try to define a new model to do research that can be translated without the length of the validation of the process, increase sensitivity and specificity of diagnostic tools. That seems very easy to do, but it's not so easy to do. The research on diagnostic, the Italian government launched a call for 40 million of new diagnostic systems, but no one applied in the field of infectious disease. We have a lot from cancer to neurology to cardiovascular, but no specific application in this area. Otherwise, in the European project of the international continental interest, where UK is also participating, we have a lot of participation, including in infectious disease. And new technologies. New technologies is a new chapter to control the epidemics. New technology for diagnostic. We need to move on from sequencing to innovative system for direct sequencing, and also approach with the computer science and digital surveillance. The third bullet point was to have a forum to assess experience for COVID-19 and rewrite the international health regulation. And next in the first week of December, the process will move on to this. What has been emphasized by COVID in this context? The problem to work on the political and legal instrument of and the leadership at EU level. The rewrite the European Treaty. I know that UK is not more in the European Commission, but of course is important participation of UK in the new Article 119 of the treaty, where we have problem in defining a common surveillance. When I see ECDC reports in grey UK, for me it's very terrific. And the third is try to define model for implementation of measures. We need to promote in research and implementation. Research and implementation of measures is sociological, is communicational research, and we have no specific area to working on the model of training. Apart from the lack of real perception of One Health approach, a lot of people consider One Health as a box where you put into box human, animals, and environments, and like in a freezer, and you state, no, this is not real. We need to refine a strategy for One Health approach, and with the model for collaborative research partnership. Collaborative research partnership are supported by EU at the moment, and there is also the possibility and the participation of UK in this new model for research partnership. But we invest, and maybe that Rino Rappuoli will add more specific detail. The Italian government invested with the money of research through the establishment of a national pandemic center to increase research through investment in research. This is the goal of the creation of the National Pandemic Center. This National Pandemic Center is parallel to the model in Belgium or in Japan, and this is parallel to the activity that in UK is performed, for instance, in Oxford, to support national government in the specific activity with the specific mandate that are different from the basic research, are considering also possibility to work on the model of research from the safety procedures, replacing some activity of manipulation, and also criteria for participation in genome data sharing. The participation of Italy to the model for genome data sharing and pathogen sharing has been signed by the former Ministry of Health, and this is one of the chapters to promote research. In this, we plan to reduce dependence from foreign contribution. This is very important. The goal is to have an integrated systematic approach, not only one single event at one single time, to have a common model that can be used not only for viral disease but also for bacterial disease, with a specific focus on the antimicrobial resistance. This must be integrated also with other main activities that are supported not only with money of research but also with money of prevention through the agency of the Ministry of Health. If you look at surveillance is managed with the Ministry of Health and National Institute of Health and the regions. Interdisciplinary research, we have the large EU grants at the moment. We scored very well at the EU level on this field, but we have to work in the other pathogens with the pandemic potential. For technology transfer, we invested in special call for technology transfer, and by the Ministry of Health, by the Ministry of Research, and by the Ministry of Development, and at the Ministry of Development has been established a new institution where Sergio is in the board, that is the Enea Biotech, to support activity in the high risk activity, the need of monitoring, including non-health sectors, and the collaboration with national and international players. So this is our perspective, and all the activity received the money by the government, and I'm confident that we can contribute and restart some model of activity in collaborative research on a specific topic with the UK. Thanks.
Thank you, Professor Ippolito. I now invite on the stage the first panel, Professor Sergio Abrignani, the chair, professor at University of Milan and scientific director of the National Institute of Molecular Genetics, Dr. Sahir Garbia, director of genomics at the UK Health Security Agency, Dr. Rino Rappuoli, scientific director, Fondazione Biotecnopolo Siena, Sam Robson, reader in Genomics and Bioinformatics, University of Portsmouth, and from remote, Professor Fausto Baldanti, University of Pavia, and Fondazione Policlinico San Matteo.
Thank you. Thank you to the ambassador first, but also to the science innovation staff of the embassy that organized this meeting, and thanks to the previous speakers that set the stage. When they asked me to chair this panel, I asked what do we expect at the end of this day, because all the slides that were presented to speakers for me were excellent, very thorough analysis of what went wrong and what should be in the future. But for us that have been around in this area for more than 20 years, it's sort of deja vu, because all the slides, the exception of few names, like for instance, genomics was not there when we had the senior meeting in 2003 after SARS-1. But all the contents are the same, so we should really focus on how to put on the ground what we think must be done. Obviously, we have analyzed what went wrong, and okay, the goal of this panel is focus on genomics and how genomics can help new diagnostics. I'm reading the title of the conversation of the roundtable, or vaccines or therapy. So, in the end of this session, the idea is to start with a few questions on what went wrong, in terms of quantity, what we did, or quality, what we did. And we discussed briefly before the roundtable we say here, and we're really discussing for a long time. But I will start asking, a few questions, actually the same question to all the participants. The first question, diagnostics, is what can we expect? Because what was a real success in the first original, in 2020, was the make of vaccines, because we're so, hopefully we, the community, were so outstanding making vaccine 9 months. So it was a success story. Now we're aiming at 100 days, so it's only a matter of quantity for what we want to do. In terms of diagnostics, it's also a matter of quality, because we're missing diagnostics, we're missing the way. Many countries didn't have any diagnostic industry capable of allowing quick screening. So the first question I would ask for the audience here is, what do you imagine to have a better facing of the new pandemic in terms of new diagnostics? What are we missing? How should we, what should we be doing and proposing? Because the aim of this meeting is to, in the end, something to propose to people who are deciding in the end, in terms of overnational coordination and new diagnostics. And then I start with the question, then I sit down and become a panelist. So in terms of vaccines, we realize that was a very successful, is a very successful story. It's only a matter of squeezing from 9 months to 3 months. It's only a quantity issue, and within the arena, because it's the vaccine person, new things. And about new therapeutics, new therapy. So how can we, because the therapy, essentially what we did, we developed the drugs we had, we reuse, if you like. So the way we can accelerate new diagnostics, so new therapeutics for a new pandemic. So gender modality should be connected from parterre. It's there, and so with gender balance, I need more time to set you. Okay.
Hello, everybody. I have some problem in hearing because the volume is really low.
Is this better?
A little bit.
You know, I'm very good at shouting. I can try that.
Okay.
Thank you for that. So, I think it's a challenging thing if we're trying to cover looking back and also deciding from what has been developed, the experience from COVID in parallel to the 100 years of experience they have with infectious diseases and public health responses to it. Somehow, is there a balance that we need to consider when it comes to diagnostic of the fact that we have always worked on piecemeal? We responded to a certain pathogen, or we responded to a certain outbreak in an incident. And as a result of that, we don't have sufficient coverage of that biological infectious disease properties that are there that makes preparing a focused diagnostic testing at a rapid time absent from the spectrum. When genomic came in, for example, when the first genome was in January, it meant that you had a blueprint to work with. If we have sufficient surveillance that is taking place all the time to see what are the changes that are happening in infectious diseases and its biology, if we have the capacity to continue to ensure that there are diagnostic syndromic or spectrum of various pathogens, then the chances of something passes between the gaps is a lot less. And it means that we've got a framework to work with. So we've discussed earlier, if we are looking at sources of infectious diseases that might be responsible for the next sets of outbreak, should there be a framework and an infrastructure that says, well, if we had a respiratory spectra that cover the various coronaviruses, flu, RSV and others that were part of common framework that's there, then it becomes obvious that the cases that clinically presented with the symptoms but did not match any of these pathogens were something unusual that we could work on. So we've discussed earlier whether we should be considering both a level of surveillance that continue to see what are the changes in the biological framework for the various infectious diseases, and it can be ranked by risks, it can be ranked by sources and impact, and at the same time, balanced it is a capacity of ensuring that the diagnostic testing is pushed up on the framework and we get more multiplex-based, spectrum-based, syndromic-based diagnostic. So we start to reduce the gap that we need to address at a time when we have severe infections, we have a lot of illnesses, and we have a major response in the country. So I think that's part of the discussion we had. I just wonder what you think about it, and do you think does that make any logical sense to you? Yes. We're doing a table balance now rather than gender balance now.
It's going well. Yeah, I mean, obviously there's sort of a lot of work going on right now to try and develop what those frameworks might look like with surveillance within wastewater, how that can be targeted more directly to a clinical setting, so perhaps looking at wastewater directed at hospital sites, for instance, so that you can get a more targeted approach at looking at that surveillance. And then I know later we'll be hearing about more sort of broad-scale diagnostic approaches for looking at respiratory diseases, for looking at other types of diseases. I think one thing that the genomics work through the COVID-19 pandemic has shown is the importance of tracking variation in the virus and being able to understand when new variants come out. But obviously the resources that were required to do that were quite major, and whether or not we can continue doing that into the future of taking every single sample that ever comes into a clinical setting and doing genome sequencing of it is highly unlikely. So coming up with a directed approach that can still identify when changes occur that are of clinical relevance, I think is going to be tough to model, but I think that developments in technology are really helping with that as well. I think it shouldn't be understated how much technology has played into our ability to look into that, not just genomics, but kind of everything. I often think about what the pandemic would have looked like 20 years ago before we really had the internet in the way that we know it today. And things like that have had a massive impact on what we can do with data. And then mentioned earlier on about exploring those data in more detail with machine learning approaches, with more in-depth data analysis. So, yeah, I don't know if that really...
I mean, yeah, it's interesting, yeah.
Thinking a bit more on the specific word to propose something which not happen to an ideal European organization that does not exist at present, discover they should get ready for the next pandemic. They should recommend something that use all the European borders. So actually, what would we recommend? What should we recommend? So, in practical terms, I mean, the kind of respiratory common viruses, whatever, but deal with the major response. So we're discussing sort of priorities, what should be recommended. So I would invite also Fausto, that is
Yeah.
psychologist. So if you can comment on
Yeah,
that.
if I may step in,
Yeah.
okay, I do really agree very much on what was already said, and of course, it is something that is not happy to be said, but we already have a lot of diagnostic panel for respiratory viruses in several years, but they are not widely used. If they would have been, at least in ICU patients, maybe the pandemic could have been intercepted earlier. Only just to identify patient in severe conditions, negative for everything, and then looking for something else, as pointed out. That is one thing that we should really think about. As for the genomic assessment, so the analysis, in-depth analysis of the genome, as you know, Lombardy was the first region in Europe, in the Western world, that was hit by the COVID-19. And immediately during the first wave, our hospital and another hospital in Milan, we did run a full genome analysis of the COVID, and discovering that the two major outbreaks in Lombardy, one that was Lodi on the south of Lombardy, and one in Bergamo in the north of Lombardy, were sustained by two different variants. Okay, and we all remember the difference in the severity of these two outbreaks, because the picture, the images that have been reminded earlier in those really dark days in February 2020 were in Bergamo, and there was a different variant from Lodi. So this is really plastic image on how much a different variant can impact on a disease. In my opinion, also, another thing that was lacking and is still lacking is quantification. So how can we measure improvement or failure of treatment if we miss to quantify the virus in secretion? So this is something that is still missing. Finally, on the genome side, in order to have a global surveillance, we should be able to intercept what is still unknown, not only by similarity, but also in a proactive way. So we need to develop metagenomic approaches to intercept something that we might not think of in that specific moment. we tried a metagenomic approach during the hepatitis of uncertain etiologic origin early in this year, and finding that actually all these cases, these pediatric cases, were sustained by a combination of common viruses, but a combination of them, using a metagenomic and a really open-minded approach, not pointing in one direction another one. And so that might be an example on how useful could be to have protocols also in that direction. Finally, of course, the very big improvement in this situation with respect to the previous one was the data sharing. Not only because the Wuhan sequence was available on January 6th already, and everybody could use that for developing in-house systems and whatever, but also because all of us, we were really engaged in publishing and submitting also preprint in repositories. So data were immediately available, also before accepted by the journals. This can be a risk, of course, of low quality science, but is also a mean to have immediate access of information. That in order to confront with a new entity, speed and fast communication is really important.
Thank you. If I may just summarize just 3 points that to me is building on. One is to be able to detect something unusual, unknown, you need to know what's the known. So we need to have mechanisms of ensuring that we have standard diagnostics and standard surveillance that do survey what we already know. If we have that, that gives us the baseline to detect when something unusual is there. The second part is, I think in the case of COVID, the lack of sufficient genetic data in the background meant that we needed to go the extra effort, and genomic played a major role because we had poor severe data. I keep saying, Susan, that if it was actually salmonella, we would have detected it in 3 days because it's probably among the bacteria, it's the highest number of sequencing among pathogens that were out there. So having a system that is unbiased in the background to ensure that we have surveillance of if pathogens at different levels or on agreed standards perhaps is needed in the background, then you don't need to go with that amount of intensity and cost at the level that we needed in order to collect sufficient information. And this one of the third piece that to me which makes a significant component that the colleague had mentioned is the fact on genomic data sharing. So in the UK, in public health, UK HSA, we are committed and we publish our genome sequences with literally in gastro and TB within 48 hours. When Nick Lohman is here and Tom, and will tell you as COVID genome was coming through sometimes before we even analyzing them, they have been putting that in the public domain. That speed of having that data in, but also our ability to look back and ensure that as an epidemic or an incident grow, that we start to add quality assured data and put reference genomes out of that we are assured with, because that acts as the basis for the molecular diagnostic tests. That's the ones that will work for vaccine. Moving forward is that set of intelligent quality data that counts. I don't know if that summarizes just some of the 3 points that we were reviewing, and maybe from a vaccine perspective you wanted to comment on it.
On the vaccine, one thing about the diagnosis is that if we had for instance, in Italy, in January 2020, one of the heat of the unknown, business, the unknown, it could be based on the coronavirus, on detecting more or less all the coronavirus, all the flu viruses, eating that you can detect easily, genomically, all of them. And there is a list of 7-8 viruses which are at high risk of causing we had this access, what I consider a level genomics, it would be something that would have, because after that, after you fail a test and you diagnose like a lateral pneumonia of unknown origin, you have a run, you should test immediately with this kit of technology. And we would have detected that it was circulating already in January. So we should propose something like this. So it's
just to raise the point, so at the moment we talk about genomics as something separate from diagnostics, right? And I think the direction we need to move into is genomics being equal, like you said, in the diagnostic part. So you're talking about then talking about the idea of perhaps an unknown related diagnosis of neuroimmunology. That process thing is really involved in genomics and those things.
Yeah.
And that in terms of reflecting the fact that some of what we saw in the pandemic, actually thinking about genomics as part of that diagnostic part of it is critical in terms of the speed you're able to get, in terms of getting samples through and data generated as well. And certainly early on, there are a lot of people who weren't used to genomics being the end of it. So your lab teams were used to running their molecular tests and then chucking all the samples, etc. And then you've got the whole issue of getting the logistics to actually get the genomics part comes to the end. And if I were going to change one major thing to enter the next pandemic, it would be to change that mindset and get people to think of genomics as that final step in the diagnosis pathway. Because then that opens up everything else you might want to do, whether it's enabling surveillance, intensive surveillance, whether it's detecting unknown pathogens, but that systematic change is what's required, I think, and that sort of system.
Yeah, but Tom, I agree, and that's in an ideal world. The difficulty is resourcing. Then you've got thousands of people that are in the clinic, and you need to decide which ones and what you're going to do with it. It's in that spectrum, what are the pieces that there, and what is the front-end funneling need to be in order to establish a framework that goes. I totally agree with you, but the reality is genomic is expensive, and it's going to continue to be quite expensive.
Why not? Why not?
Just with 50 minutes of our round table, we've been for 20 minutes on diagnostics. Now
Yeah.
in the
Well,
vaccine.
no, I would like to comment on what has been said so far. So, the cost has been shared many times. I will try to remind that this pandemic costed 28 trillion to the world. The consequence of that is that, was pretty expensive. We made with David Bloom at Harvard the calculation of what we require to have the world ready for the next pandemic, and we came up with a paper that's entitled $1 trillion Gap. That means if we really want to be ready, we need to be able to invest. $1 trillion is 0.001 on the global GDP. It's not that much. If it's able to save it 28 trillion once, and pandemic is going to come and more, it's a good investment, I believe. I leave it to the economists to do this, but I would like to remind them, we're talking about making an investment, not saving money. The second thing is that I fully agree with genomics. That's the end thing. We learned during this pandemic that genomics was driving the decisions, the things, the vaccine development, the diagnostics, the variants, everything. Now, is it expensive? Yes. When I started doing genomics with Preventer 25 years ago, it was much more expensive. it's become cheaper and cheaper and cheaper, and will continue to get cheaper. Why genomics? You don't need to know what you're looking for. You get the known, the unknown, you get everything. What should we do in terms of new, we have networks globally run by the WHO to pick up influenza everywhere in the world. We have networks to pick up polio everywhere in the world. Let's make one network that's not going to detect polio or influenza. It's going to do genomics, it's going to detect everything. It's not much a bigger investment. I think we need to change the way we work. We need to change our mindset, frame shift, and go into doing the science and the surveillance like we should do with the technologies that we have and knowledge we have today.
And the risk now is what I'm perceiving, not only in Italy, it's attention and tension on pandemia is going down.
Oh, yeah.
And therefore, while 1 year ago it was still seen as a priority, now they're thinking like political or key people thinking how to save money rather than how to invest to be ready for the future. So the major risk really is a decrease in attention and tension. And therefore, when we talk about it is an investment, it is an excellent value for money. The calculation you publish is unquestionable. But at this point, it's not a value creation. It's seen as a cost. Because there is no tension. It was 1 year ago still, and now I perceive very clearly it's going down, and there is a...
But it is our job, or scientists and things, basically to, and not only scientists are doing genomics or vaccines or things. We should have troops of economists that basically are going to make the case that health is keeping the world healthy is an investment, and is the best investment with the best return on investment you can have for the people, and for the economy.
I couldn't agree more. The problem we have is that the slides we are showing now are more or less the same slides we showed after 2003 SARS-1, after the swine flu 2009, in the 90s we had all this meeting. It's not the issue if, but when it will come. And the slides were all the same. A few words, genomic was not the word at the time. So we should be more aggressive on putting numbers and proposals. We've been a bit, probably not you or I or other people in this room, but as a community, we should be more incisive, more insisting on this. So
my proposal is that we should bring many more economists to these meetings. Those are the guys that make the numbers that convince the decision makers.
And politicians listen more to economic people than to scientists in sciences. That's for sure.
But one of the questions that continue to be is, which I think is where a lot of the policymaker, with the budgets, the treasuries and others are saying, in between pandemics, what are we using, the framework, the technology, what we're developing? And I think there is an opportunity for us to work in that space where we continue to be prepared, but say, how do we maximize the public health impact by using that same framework, the technologies in it, the partnership, the collaboration. What are the things that can elevate or reduce the impact?
Definitely. And also, since we don't have many people there are things to happen.
So you'll be hiding at the moment. You want them to do a lot of
hiding.
work.
No, but my question is, I agree 100% with Rino, but since we do it, either we terminate now with roundtables, or we try to say, even without people from the economic department, we can come up in the next 20 minutes, because we're just 25 minutes, with a proposal that somehow makes sense and reflects what we think are priorities in our the use of genomics in vaccines and therapeutics and diagnostic, and possibly in common view, One Health of veterinarian. So the question again is, assuming that you're right, we need people from the economic department, but we do not have. Since we do not have, as life science scientists, at the end of this 50 minutes round table, what shall we write in 3 sentences that is not already all the hundreds of slides we've been showing for 10 years or 20 years. So this is something very...
Why don't we ask
So
colleagues
to the ground.
for
Yeah.
2 or 3 volunteers to see what they think. They heard some of the debates we were having. Let's have this as a room discussion.
The framework that we're discussing, though, I mean, genomics in diagnostics, it's not only for infectious diseases, right? It's for health in general. So bringing those capabilities into the clinic and having those capabilities in general is a benefit for diagnostics of all diseases. So is that not an avenue to take with it, to say, you know, we're not just talking about pandemics, even though that's really important, it's for health in general?
In Italy, 2020, 2021, we've been very poor in sequencing. We've been, I think, the worst country in the Western world in terms of virus sequence and tracing genomic sequences. So when we propose to have a few centralized important labs, they should be always running. And the question was, yeah, but the pandemic is going to end up. And then what we do? Our proposal is used for genomic in cancer to optimize treatment of patients. It is a major problem because once you have an important genomics laboratory, moving from a virus to cancer cell is different, but it's the same instruments, use the same technology. So that's something we should use as an argument. That it's not an investment is only for the pandemic. Once you have a huge capability of sequencing, can be used for other purposes that are important for public health and cancer or other type of diseases. So this for the diagnosis. So if there is any issue from the audience in this diagnostic issue or genomics in general,
I would turn my colleague Mira. Totally agree. No, I totally agree, and I think that's the debate that we were having, which is how do we ensure that balance. But I think COVID had proved to us that there is a perspective of community and wider detection, which is something that hasn't been as part of the configuration of our public health response. Is there opportunities now to sit down and look at that and say, as part of pandemic preparedness, there should be a community fraction of surveying what is circulating. Yeah. Yeah. No, I meant surveillance. Oh, yeah, I wasn't seeing it from a... Yeah, but I totally get your point.
can you see your name? Can you say your name? Sorry.
Can I say, I know we've gone into this quite a lot, but I think let's give also opportunity for one of our colleagues from here, from Italy, your perspective on this, what that is, just so that we have a, you know, a balanced perspective on what you think. I think you can pick on one of our colleagues to say, yeah. Yeah? Yes, please.
Proposing testing with this kit for the now wastewater.
Yeah.
So if we move now to vaccines, you know, because one question, vaccines have been a very important success story in the pandemie. But do you think genomics, I mean, it's only a quantitative thing. We should squeeze from 170 days to 100 days, speeding up the pipeline, or there is something else qualitative that can be changed in the vaccine making process?
Well, obviously, the major things that has happened is basically the availability of the genomes allows you to develop vaccines, develop diagnostics, without isolating the virus or the pathogen. So the value of genomics is incredible because sequence go to the internet at the speed of light, and the moment the Chinese put that into internet, immediately 350 labs worldwide were able to download the sequence, make a synthetic gene, and started to make a vaccine overnight. And you can make vaccines 1 week. So I call that digital vaccines the new era because it's basically you don't trade viruses anymore, you trade sequences. They go through the internet. You make a synthetic gene based on that information. You make an RNA vaccine, which is actually not a vaccine. What you inject is in information, which is in the RNA, to make the vaccine. It's our cell that make the vaccine. So everything is basically digital. We're not dealing with virus or bacteria or real vaccines. We are dealing with information that goes from two letters, 0, 1s, to basically four bases. And so that's, I mean, it's a new world. We didn't have that before. Now, then the question is, can we do better than 10 months? There's been a study which has been run by McKinsey and, well, by the CEPI in London and by the McKinsey group. And they asked the question is, what can we do to make vaccines 100 days? And they looked at the way we make vaccines, and they said, what if we optimize every single step? If they optimize every single step, the best we can do is 250. But if you change the paradigm shift, now we can go, can have an aspiration to do 100 days. And the 100 days is technically feasible, but practically impossible right now. But technically we can do it. From the sequence to first in humans, we can go in 30 days. Actually, I think we can do in 3 weeks technically. Then you can run phase 1, the clinical trials in 60 days, and then if the regulatory agencies have been involved in the meantime, in 10 days they can approve it. So technically it's feasible. Why is practically impossible? Because to do that you need to be prepared. To be prepared you need to invest. It's like running 100 meters. If you want to win, you need to be on the blocks. If you start running when you have to buy the shoes and dress up, I mean, you're not going to win. So that's the kind of investment we need to think about. We need to think about being ready. Means that we need to, if we want to make a vaccine for any surprise, at least the ones we know, we need to basically, before we get there, identify for each virus family which are likely to come, and for all of them, basically prepare one vaccine for one member of the family of the virus, we call prototype vaccine, and bring that to preclinical studies, animal studies, discuss with regulatory agencies until we know that vaccine for that type of virus is feasible, and if a virus of that family comes, the regulatory agencies, the manufacturing, everything has already been done. Then when it comes, you can go, and then you can start your 100 meters run. So that's the thing we need.
Yeah.
Yeah, that's prepared. And
Yeah.
So I think the words of Rino are really synthesizing the concept of preparedness, and now we're going to talk break, which is really
sounds good.
It's just it was intended as a very quick break with some water and just stretch legs.
Yes.
We are a bit late, but we can stop for a few minutes and then reconvene the second time.
Thank you.
So there's no coffee. I'm sorry. I thought because in Italy you're always coffee.
Thank you very much. I have the pleasure now to introduce the second panel with Dr. Susan Hopkins, Professor Silvio Brusaferro from the Istituto Superiore di Sanità, Christoph Fraser from the Nuffield Department of Medicine, University of Oxford, and the chair Eric Volz from the Department of Infectious Disease Epidemiology, Imperial College London. Thank you so much. Buon lavoro.
Good afternoon. Thank you again to the organizers for arranging this wonderful forum and workshop. I think I should say a little bit more by way of introduction before we begin. So on the end, we're joined by Professor Christoph Fraser, Professor of Pathogen Dynamics, of special relevance to this meeting. He has recently been principal investigator in 2 large pathogen sequencing studies during the COVID pandemic. He was also instrumental in using digital sensing technology, smartphone data, shaping the pandemic response. Silvio Brusaferro is president of the ISS and also runs the UNITEPS organization, which is a European-wide effort to promote infection control in healthcare settings. And I will try to speak about that. Sorry. And Susan, of course, has already been introduced, and she is the Chief Medical Advisor for the UK government. So thank you all for being with us, and looking forward to an interesting panel. To start with, and I think based partly on our discussions in the last panel, I think we should begin with the COVID pandemic, which was a very unusual event, but I think will shape how we think about epidemic surveillance for many years to come. So I think we should reflect a bit on the experience in the UK and the experience in Italy, which was quite different. What were our strengths and weaknesses? And then that can then lead to a discussion about how we can collaborate more in the future. So from my perspective, I was an academic scientist working very closely with UK HSA over the course of the pandemic, and it was a very unusual situation. Typically, as someone in academia, it is always a struggle to get data. And the pandemic was an alternate universe where, in fact, everyone is coming to you and trying to make you use their data. And I think I already miss it, actually. But this was obviously unsustainable. But maybe there are some very good aspects of the breadth, the amount, and the quality of the data that we had during this pandemic that we can keep going forward. Also one final note, please do feel free to chime in from the audience, because really there is a lot of expertise in this room, and if you do want to weigh in on any of these questions, please do shout out. Maybe we can start with your reflections, Susan, if you could expand a bit more on what you talked about earlier this afternoon.
Yeah, so I would say at the start, the first 90 days, the critical 90 days, there was a dearth of data, there was a lack of data. We had really no idea how many infections were occurring in the community. We were getting sight of sick people in hospitals, and like yourselves, people dying. So therefore they likely had infection for 3 or 4 weeks. But very rapidly, and actually Mira will remember the weekend when your cases were reported in Italy, we devised a surveillance protocol for everyone in ICU to be tested for COVID if they had a respiratory admission. But it took, people were scared. People were scared to test. They were scared to find out what was there and what would they then do about it. That changed very rapidly, such that we have the largest surveillance system that we've ever had for any pathogen. So we had at one stage, two very big community studies happening for community prevalence on randomly sampled individuals from the population. We had very accurate data on the number of people being admitted to the hospital every day and the number of people being diagnosed in hospital with COVID, the number of people in ICU, the number of people dying, and we were releasing that data on a daily basis. And we were sequencing I think at the peak, almost 100,000 genomes a week for COVID. We were previously sequencing 100,000 genomes a year for all of other pathogens. So a step scale change in what we had. And I'll leave Christoph to talk about some of the other data that we had available from our sort of tech tools and our app to contact trace. But we also had huge amounts of data on people testing in the community and being able to use lateral flow tests to test at home and reporting those tests, and then being able to identify who was being confirmed by PCR tests. So a complete different scale and range. And I think the learning is that data was power. It allowed us to provide insights. It allowed us to detect changes in the epidemiology of the virus and the variants that were circulating. And if you look at what happened with Alpha variant, then Delta, then Omicron, the speed and scale of being able to detect those changes, to be able to characterize the virus, and to be able to understand the impact on severity and hospitalizations and death was mind-blowing. I mean, for Omicron, from the date of detection in end of November, the 23rd of November, as I recall, I was playing tennis, and Mira texted me to say, have you seen what's been just put up? To less than 3 weeks later, we had a pretty good idea on severity, on the spread, the transmissibility, the change in immune response, which was of a rapid scale. I think actually post-pandemic, we'll have to learn to understand what were the most important pieces of data and how can we capture those at the most cost-effective way.
Thanks. And so I think everyone recognizes that the UK was out and out ahead of most countries in terms of its uptake and sequencing. It turned out to be very important, and everyone recognizes the importance of the importance of sequencing for understanding variants. The Italian experience was quite different. So Italy was the first country to be heavily impacted by the COVID pandemic. A lot of your analyses, Silvio, were actually quite important for shaping policy response. You provided some of the first estimates of case fatality rates. So in your experience, how does your response differ from that of the UK? What was done well and what might be complementary?
Well, first of all, thank you very much for inviting me to participate in this panel and to contribute to this reflection. Well, I try to, all of us, we know the story, so I don't want to go into the story and to remember a single episode, but I try to focus on 3 or 4 keywords. The first one is time. What we discovered right from the beginning is that we had some surveillances, influenza was one about influenza, but was not so timely that as timely as we needed during the pandemic. That was on daily basis collection of data, daily basis collection of samples, and so kind of thing. So it was a radical change to keep for a long time. Last Friday we released the 131st weekly bulletin that in the history of our country we have no precedent of that. So we are doing this kind of things. The first one, so time is very much important. This was completely different. And we had to, in few days, to rearrange our systems that were traditionally collecting data, reporting data, in sort of proactive collection of data and sharing this kind of data. Time means also validation, because you have a good validation overall when you have a global scale, national scale, is something really very much important. And the second word is scale. Even if the first wave in Italy was almost northern part of Italy, or the larger part of the cases were just confined to the Lombardia, Veneto, and the Emilia-Romagna. So the northern part of Italy, because of the lockdown, the central and southern part was not eaten in the first wave. Nevertheless, the scale was so large, so we have cases from Sicily, and so we have to, in a country like Italy that has some differences among regions in terms of efficiency or reporting of eradication of public health, That was a very, very big challenge, and was something overcome very briefly. So the other experience is that in very few weeks, in very few days, all over Italy we were able to set up the system. And you know, we have some parts of Italy that were reporting in written papers, the cases, the other one by the computer, but within few weeks, within few days, we were able to report it. That is a great experience too. It is still becoming very much important. The third one is just open data. So right from the beginning, what our decision was to share data as soon as they were validated, of course. And we published all our data, and within a website, so we're open to everyone who was interested to do that. And this is something we believe really very much important during such a kind of episodes of pandemics we're living, because of course there was a big discussion because all people wanted to do models, wanted to provide new models, forecasting, everything. But the first important thing to do everything is having data and sharing data. And we did it. That was very much important. We still continue to provide data and database to all the researchers that are interested, provided that the GDPR, that means privacy, are safeguarded. That is very much important in our regulation, even if it's not really well understood from all over also the science. But this is another big challenge that we have to keep in mind and to safeguard as a public institution like we are. The other thing is the pandemic and the surveillance changes along with the changing of the pandemic. So what we started in February, March 2020 is not anymore the same thing. Of course, epidemiological definition are the same, sequencing is much the same, but the parameters, the interpretation, the way we report data should be modified according to the evolution of the pandemic. And that is another, so there is not one ballot available for every season. Each season needs some special attention. So epidemiologists, public health professionals should be very, very attentive in find out when a phase is changing and adapt indicators, suggestions according to the new phases. That we learn. We are still learning about that, I think, because one of the challenges we have now is, for instance, long COVID or kind of things like that, that are very much important, but they are not the headline of the newspaper, let's say, in some way. The last thing is that, surveillance is many aspects. Currently, in our country, we are just running on a weekly basis. We have a genomic reports, we have an epidemiological report, we have a vaccination report with the impact of vaccination, different categories of citizens, but also we have a wastewater report. And that is extraordinary experience, let's say. It's extraordinary, the pandemic, but this kind of experience is very much important, even in perspective, thinking about antibiotic use, antimicrobial resistance, putting together data from wastewater, from genomic, from epidemiology, this kind of thing, putting together, being able to merge all this data together, give us a great opportunity, and then thinking to other databases like drug consumption or whatever you want, could be a really great opportunity. And we learn about that, and also a country like a national system like Italy that is regionalized, so we have differences within 21 regions and provinces. So Santander is not really homogeneous. Today is ready, it did it. And if you look at our data are homogeneously distributed and collected from Sicily to the Bolzano to Trieste, Udine, that is the city where I live, the far east of Italy.
Christoph, do you want to add anything, maybe from the perspective of non-traditional data sources, since, and correct me if I'm wrong, during this period of the initial pandemic, you were very occupied with smartphone surveillance.
That's right. So at the beginning of the pandemic, so we'd been interested in the past in contact tracing, test, trace, isolate, quarantine policies and their effect in mitigating spread. And I think in considering how we respond to outbreaks and pandemics, there's always a bit of a tendency to focus on the last sort of major experience that we had. But looking back at a very similar virus, SARS coronavirus 1 in 2003, more severe, less infectious, but genetically very similar virus, it was contained, having spread extensively in 6 countries and affected 23 countries. It was contained with test, trace, isolate, quarantine. So I think that was a reasonable start to think, that was a policy that needed to be beefed up. But when we started to look at the data from China and Singapore, we could see that this was going to be different because the tempo of transmission was faster. There was the issue of pre-symptomatic transmission, asymptomatic transmission. So any test, trace, isolate needed to be done more quickly. But with smartphones, essentially, you have the process of digitizing part of that process, not all of it. You still need to test people, and you still need a behavioral response in terms of what happens. So that was the basis of the why you'd want to use contact tracing apps. You all know that the story was extremely politically challenging. Integration into health systems was really difficult. I think Susan and the UK HSA really helped a lot in the UK in terms of making sure that the testing and the digital, made it possible, and it was difficult in other settings. So there were major challenges, but there were some successes as well. I mean, it was used by a lot of people, about a third of the population in the UK, and pre-vaccine averted, even with very conservative estimates, about 1 million cases prior to the introduction of the vaccine. I think from a surveillance perspective, contact tracing tells you something else. It tells you about the transmission routes, the transmissibility, and right at the beginning of the pandemic, if we had that system in place, I mean, we can see now retrospectively, for example, how does transmission actually vary? Is it 15 minutes? Is it half an hour? Is it over 6 hours? What does the transmission rate look like? We have this rule, sort of 2 meters, 15 minutes. Where did that come from? So you can get insights into transmission which are not available by traditional methods. You can use sequencing to corroborate that between your digital tools and what people are reporting with manual contact tracing. The other thing that you can see is you can, and we saw this throughout the pandemic, you can see sort of really early indicators that there are changes in behavior and that there are changes in transmissibility. So we saw this, changes in behavior during early 2021. We saw really large reductions in contact rates when Omicron occurred. So the advice of the UK HSA had an enormous impact on people's behavior, even though it wasn't at that point sort of mandatory. But you can also, you really have that real-time data. So the genomic data can be quite hard to interpret. Is this a new variant? Is it really having a major impact? And if you actually look at the contact tracing data and you see that suddenly the secondary attack rate, has jumped up by a factor of 3 in the same area of England, we could put out, and we did put out notices saying that something funny is happening over the last 24 to 48 hours, and that's really helpful. The difficulty is that we don't have a mechanism for using these kind of tools now to help us sort of in the preparedness phase. How do we sort of leverage the fact that we have this technology, who's coming into contact with whom, but there's also very linked to sort of politically sensitive issues and privacy, which is basic value in a democracy. But it is possible to do a lot more than we did. In Singapore, there was sort of 100% adoption of these things, and with some encouragement, it's a different form of government, but that did maintain a whole year's worth of essentially having no epidemic wave while still having a fairly open society and having people traveling to and from. It wasn't an absolute COVID zero sort of setting. So I think there's a lot of promise in the future. But just returning to the point of discussion here, I think the interpretation of early sequence data is actually really difficult from a transmissibility and from a clinical perspective. So we need a multi-data perspective on this. I do also have sort of a couple of thoughts on the issues around early sequencing as well, but I can come back to that.
Oh, we can go back to it if you like. I think a common theme from everyone's answer was the difficulty of data integration when you have different types of data, and the importance of very rapid sharing of data. Considering contact tracing data in its various forms and sequence data, for example, these are things that can be very important to integrate. When I've looked at the UK data, for example, I see that a non-negligible fraction of contacts that are supposed to be transmission pairs often have sequences which are not compatible. And I guess as the complexity and the types of data that we keep bringing into our surveillance systems increases, these sorts of opportunities and challenges just continue to grow. So another common theme or difficulty that you all raised was legal issues, which I briefly during the pandemic looked over. Well, maybe looked over isn't quite the right phrase, but in the background. But now as we try to make our surveillance systems more sustainable and have common standards, things like GDPR, informed consent when surveillance data are used for research, these are important issues. And would any of you like to comment on how you're dealing with these issues right now, specifically data integration and legal requirements? Christoph?
Yeah, sort of maybe answering obliquely. I think with regards to data sharing early on when we have a new outbreak or a new variant, at the moment the situation is very good for sharing pathogen genomes. There's a real culture of open data. There are platforms, where as was commented, people post genomes within days of a new outbreak. In fact, the COVID, the SARS-CoV-2 genome was shared fairly quickly. The problem that we seem to come up again and again is putting that into context of the things which allow governments to start knowing how to respond. So how do we get at the severity? How do we get at the transmissibility? And those data often are considered sensitive and are typically not shared. So when you have a first fatality in a country, the government typically likes to manage that information and about the severity. And if you think about how useful those data are, if at the beginning of COVID, if you go back to swine flu, I think swine flu is an example where there was huge amounts of very mild infection, and it influenced a lot of the reluctance maybe to act very quickly at the beginning of COVID, because did we have the tools to be able to know whether or not there was lots of mild infection for COVID in February 2020? What was to some extent you need different types of data sharing to happen. I think contact tracing, looking at secondary cases, would be very valuable in that case. You can also set up cohorts and so on and so forth. But those are really those are standards that don't exist at the moment, I think, about how you determine the severity of a new thing that you're looking at. If you think again about Omicron, Omicron was very controversial. So I'm involved in a surveillance network for HIV in Eastern and Southern Africa. One of the PIs of the network was the person who discovered Omicron, and he gets enormous amounts of hate mail because essentially that was we consider the discovery of Omicron as a really positive thing, but they took an enormous economic hit with the countries because of our actions. We decided that the data were not good enough. The UK, I think, made the right decision, saying, you need to see what it looks like in elderly populations. The data from South Africa is not answering that question, or there's some, the data that would allow the UK to, I'd be interested in the views of others, to evaluate, what the risk is, weren't quite good enough. So there was a decision to sort of delay while you get on the real clinical severity insight into what Omicron looks like. And that was very controversial. There isn't really an agreement as to how to share the data, how to do that internationally, and what's an appropriate measure as you're trying to work out what the new variant or the new pathogen you look at really might do as it starts to spread.
Well, I see two sides of the problem. The first side is more limited and more affordable in my point of view, is trying to overall, at least in the Italian situation where we have not a centralized center for sequencing, but we have spread a network of many places, very, very qualified, but still many, producing sequencing and working on these kind of things. The first thing is just to motivate these people that are mainly researchers to share this data and to put together in a coordinated action. It's not easy, so you have to push them, you have to nudge sometimes, but during the pandemic nudging is not enough. You have to really, how to say, address in a very strong way the people to share data and then to share data with the international community. But the first one, sometimes it's easier to share from local to international and just jumping the national one. So some kind of thing like that, very technically oriented, let's say social policy in terms of how do we share data is very much important, and then to recognize the contribution we do. And this can be addressed, but should be addressed probably also before this kind of events. Of course, during this event, it's absolutely necessary. It's one of the bullet points you have to check immediately and to force the system to produce that. Then there is another one about, let's say, I call it privacy, but to protect the personal data within a pandemic. There are many structures that one of the key leaders in the situation is the data protection officer that is currently present in all the organizations, both at the national level and the local level. And the thing is that when you do epidemiological survey or contact tracing, you work with the personal data. And you collect personal data, and the fact that you know the identity of the person gives you the opportunity to link to sequencing, to link to vaccination once you get the vaccine. So this is very necessary, but still at the same time proposes many problems in terms to protect this data. In our experience, we have to work a lot. As a president, we invested many euros to create a sort of barrier to protect our database, to protect for attacks from outside, to keep this data sometimes becomes a strategic resource of the country, because with this data you can just forecast everything about the evolution of the country. So that is very, very much important. Besides the single data protection, single person protection. A critical issue, I completely agree with the colleague that the other thing is that you have the tracing of that. Then if you have at the evolution, right at the beginning you have to collect data of this person during the evolution of the infection. It's just positive and then becomes negative after a few days, or is developing some clinical symptom, is going to the hospital, how the evolution is going, and so on. And that poses a problem that you have to collect data electronically, looking at the need of time you have, not just for epidemiology, as we realized in a few weeks. The other thing was to collect the clinical records and to link clinical records. And this is another challenge because we have, at least in Italy, we have not an homogeneous approach to that clinical records. So the link is very much complicated, and but is necessary. Complicated because we should create database that can be immediately linked with the code in the oldest history of the story of the person. but the other side is how to protect this data. Because seeing if you start in this way, also the clinical data are even more relevant in terms of protection, data protection of single one. And this is, you know, a big challenge, but at the same time is, I think, one of the future we have to face, because these are what we call not real data. And besides the clinical trials or the kind of thing, during this kind of episode, if you are able to put together, to link them and provide the possible linkage before, exploring also with GDP, with the data protection officer, national authority, how to link this kind of stuff, protecting even with, you know, barriers of protection. To do that, I think could give us a lot of information. And in terms of real world, and even if you are not just doing some clinical trial or other kind of studies like that. And I think this is one of the challenges, but it's very, very difficult because, you know, you have to overcome 2 or 3 passages. The first one is to get clinical records, electronic clinical records, and linkable to the other one. And the second one, you have to guarantee under the local legislation how to use in terms of research, of course, this data and produce, you know, data that can support the chief medical officer or other people taking decisions.
So I was going to come in and just say, I completely agree with those points, but I suppose in looking at where we are now and where do we need to be for the next 5 to 10 years, what are the things that would make a difference? And I think for me, in thinking about the surveillance, is what are the critical pieces of surveillance that we have developed during the pandemic that we would want to sustain, that allowed us to have new information in a timely, rapid fashion. My first views are community surveillance as well as genomics. They were the 2 big add-ons that I think we didn't have before. The second thing is, how do we start that conversation with the population and the people? So a bit of coming back to what I spoke about before, where we often don't engage with them in the intra-pandemic period, where we talk to them about the importance of their data, why we need to use it, that this needs to be done in a very transparent way so that we can have the most insights. And I think I'm quite keen in England and the UK that we start thinking about people's assembly, about how we discuss with people, how we have those open conversations that talk about the importance of real-time, personally identifiable data and the impact it has made on the pandemic and the impact that it will need in the future. So sort of moving us to the idea that it's too difficult to, we actually did it, and now we have to manage to figure out what are the key things that we need to sustain.
Okay, thanks. Coming back to a couple of interesting points regarding electronic health records and interoperability, and the standards we have for sharing data. So I think this is most advanced for genomics, where it's accepted behavior, and many journals would require that you submit sequence data prior to publication. It's also standard for public health agencies to share genomic data very rapidly, although there is a lot of heterogeneity around the world and how quickly that actually happens. What are the opportunities and challenges for interoperability here? So I'm thinking of an example you raised, Silvio, where you shared early case data from the outbreak in Italy. It's actually not, I wouldn't say there's a standard of behavior for sharing outbreak data in a line-listed format like that. And that was an exceptional circumstance, and thank you that the world owes you for doing that. And the UK has at various times also publicly released fairly detailed, not exactly line-listed, but fairly detailed surveillance data sets as well. But this is still unusual behavior. Can we do something like that in the future? Could we maybe develop new standards of behavior where it's expected that scientific studies and health agencies release data, not just genomic data, but more standard epidemiological data in situations where there's no great risk to privacy, there's no great risk, there's no clinical benefits, and things that might make release of surveillance data problematic. For example, for many large data sets, it's practical to have informed consent. Do you have any thoughts on that? I've stumped them.
Oh, well, yes, I really hope that we can start a path where we agree at the European level, at least a European level, ideally a global level, but still is the first. Let's start from European, because we have to also to recognize and to thank also the colleague from UK, because during the pandemic we have many exchanges, phone calls and kind of thing, trying to share our data besides the official path, but because of personal contacts, trying to share data, that was very much important. I think it's absolutely essential to define also in a critical issue like that, in a critical situation like the one we lived, to have the possibility to phone some colleague from UK or from London or from Berlin or Paris or Spain and say what's going on, and get the feeling of the situation, and get also some hints that is not published, but you just think that can be evolved. That was very much important. I think we did it in a spontaneous way, and with Susan, with Sweetie, with other kind of people, and we are grateful too for sharing with the information among. The thing is that we need standards, and still till now we have no standards, and we have some standards, of course, in terms of genomics, but when we speak about clinical definition, we are still a critical issue that are not very well defined, or not all countries adopt the same definitions. One thing can be death, can be ICU use, or other kind of thing. And it's not just because of the pandemic. With Susan, we work in many projects with the ECDC about infection, hospital-acquired infection. And when you speak, for instance, about ICU, it's a sort of magma, let's say, of the system. There are different, you cannot compare countries really, because the way we use this kind of tools or the facility within the hospital is different. The kind of patient attending this are different. So you cannot really compare. This is a great offer we should on normal basis. Let's say the first challenge can be infection, healthcare-associated infection, can be something really more new, that is a silent pandemic, as we call it, but still can be done on routine way, standardized around the EU. This is, I think, very much important. The other thing is about to create this kind of channels, formal or informal. I would say formal in terms of planning, but informal. And but you can provide the informal one if you have created a network of scientists and officers that informal way they met periodically. Then you get also the informal when you need. So that is very much important. Of course, there is a scientific community. More or less, there are not huge numbers. More or less, we know each other, but still providing a sort of incubator where people get customize each other. They know each other, and they can just pick up the phone and say, "Well, Susan, what's going on?" Or Silvia, what's going on? It's very, very much important in terms of running this kind of information. Of course, we have the problem. The other problem is how to share information. You mentioned that is the role of citizen. I really appreciate it. I'm in agreement with Susan, what Susan said. We need to get them on board, and we should be conscious about the fact that we are not using data for other reasons than having good information to provide evidence to the decision makers to get the best decision that is possible to do. It's not easy. That's a sort of, and most importantly, this is the other constant I want to stress in trying to answer to your question is we should create a trust that is not just based on national level, because we live some experience in terms of surveillance. We are also living some experience in terms of data that can create or can make the trust, challenge the trust. Let's say an example. When you speak about vaccination, and when you say we have to vaccinate the elderly, and if one country says, okay, elderly for us is 60 and more years, the other one is 55, and the other one is 65, so the people say, I'm 59, what can I do? Why? I'm living very close to a cross-border, 20 kilometers for Slovenia, 40 kilometers for Austria, and there are different indications in terms of 20 kilometers. It's not just creating trust. So we need a sort of, when we speak a customized expert, say, when we said it's not really a great difference between 59 and 60, of course, we know that this is a sort of line and curve that can be, it's more or less the same. But this is making a lot of, giving the people, the population that is not clear what the scientists they're doing, and so do not provide trust. I think it's very much important to invest in that and to create trust, because trust means also I'm ready to give you my data because I know that you are using them at the best. You have to be using them for me at the end of the story. And this is a sort of narrative, if you will. We have to create the support, and this way also surveillance can do that, and also other kind of data can do that. The other thing I think finally is we should also in the narrative make clear that of course you have to agree to click a button to say I want to share my data for epidemiological issues. But you are not, perhaps you say no because my privacy is my first value, I don't want to share anything with the others. But the other thing is that when you wake up in the morning and you just send them in the Facebook a picture of your beds, of your feet or of your breakfast, you are just sharing your data. They are much more interested in terms of commercial interest that can be epidemiological data. So we are not really conscious about it as a citizen. I think as an information that science is not just an interest, it's something that interests you is very much important. And we have to do this kind of standardization among countries, sharing data, and give a clear standard that can be comparable what we do, because making comparable data give us the opportunity to act at the best. Sorry to be too long.
Not at all. Christoph, did you want to comment on that?
Yeah, I think it's worth sort of trying to see the opportunities going forwards. What was achieved in terms of genomic sequencing for COVID was truly extraordinary. If you'd sort of guessed before the pandemic, the sort of depth of insight, and actually the extent to which all of our lives as well would be governed by the evolutionary process and the appearance of new variants, just in terms of the understanding of what this work is doing and the scale of it, it was truly extraordinary. And it brought together, it didn't come from nowhere. It brought together many labs. The UK effort was led by Sharon Peacock with her microbiology background. Like many labs, we converted our HIV lab to be part of a consortium effort, and people did that all around the world. And the one question is, how do you keep that always-on approach going forwards? How do you keep gaining that insight? How do you fund that? And what's the public health and clinical utility? How do you make the case that this is useful when there's actually not that much exciting going on? It's very interesting for us to see a RSV virus emerging, but it doesn't have quite the same consequences or benefits to individuals. And I think, but the opportunity is really phenomenal. So if you think of our HIV network, being able to we're moving that over to multi-pathogens. So, looking at the range of samples, and many other networks have the capacity to do this. So I think things might look very different as we see a convergence of people who've worked in different sorts of areas, in surveillance and in clinical care, converging to generating multi-pathogen data, and if we can keep on sharing those data, the level of insights we'll get into all of the different epidemics circulating, and the ability to spot things earlier will be extraordinary.
Okay, I realize I've neglected the audience and we only have a few minutes left. So, Tom, did you have a comment on?
Working now. So the comment is that one of the things that I think is interesting is the sort of the tension. Well, it's not a tension, but the fact that the pandemic response had a research component driven by universities and a public health component. So there's a lot of analysis, obviously, that's done internally within the public health agencies, where not being able to share line list data to researchers isn't a problem, right? So in one sense, I think it's important going forward that we work out where does the research bit plug into the public health bit and how do they work together going forward, right? And I think that's understanding that synergy and making sure you've got the agreements in place to allow data sharing to happen ahead of time is something we can do proactively. I think in terms of the capacity point, I guess my question is, and I think the thing we should all be thinking about is, what are the building blocks we need to be able to do a pandemic response again in the future? So you mentioned with the genomics bit, in the UK we benefited from extensive sequencing infrastructure in universities and computational capacity that we could stand up very rapidly to do something, right? So that tells us something about what those building blocks might look like. And while I don't think we're going to need government to pay for everything we might want, if we can articulate what are those bits that we need to start with, we might get those paid for, and that might put us in a better position. So I guess it's really a question as to if there are any particular building blocks that you think would be worth, investing in for the future.
Well, that's interesting. It came up in the last session as well, how exactly we sell surveillance as something that is worth funding. Something that hasn't been mentioned is participatory surveillance. For example, in the UK, there was the ZOE study, which turned out to be very useful for tracking changes in behavior and symptoms over time. I don't know if there is an equivalent in Italy, but do let me know. Regarding new technologies in general, is this something that we think is going to be more prominent in the future?
Well, I think, just to come back to Tom's question a bit as well, first of all, there's the balance between what can be done in public health institutes that's there, and I think at least from where I sit, one of our roles is to canvass for research funding money, not for individuals, but to say these are the priorities in research, and to ensure that the research funders, nationally and globally, know what that looks like, to allow us to be more prepared in the future. I think we've also learned a lot about how we can work closer and better together, and having those data sharing agreements and collaborations in advance is useful. But also I think there are ways that we can de-identify data that allows it to be quite regularly and utilized around the system that doesn't require PII, patient identifiable information, and can meet regulations that allows that to be done more openly. I know at one point we were talking about how do we get a global line list together? What would be that global line list that we would want to see that would allow it to have, parameters that are reasonable but are not identifiable to individuals, to allow people to rapidly acquire information, and then also be able to link that to genomics, so that there's much richer data out there for everyone. My view is always there's so much data, so much analysis to go around that I'm always happy for everyone to come in and pile in, and what we need to make it is as openly available as possible in a shareable way as possible. I think the other thing that I wanted to ensure that we thought through is in the building blocks for surveillance for the future. How do we ensure that it's not centered on high-income countries? How do we ensure that there's equitable access to surveillance around the globe? How do we work in partnerships so that sentinel centres globally will actually all help, and that it's not seen as the global north doing onto everyone else.
Yes, I think we need to wrap up soon, but I can leave you with some alarming statistics. For example, a third of countries in the world, according to the World Bank, have virtually no pathogen sequencing capacity, and something like 80% of our pathogen sequencing capacity is concentrated in something like 10 countries. So certainly when we look at our sequence databases or go up to GIS8, what we're seeing is really a very slim cross-section of the diversity that's out there. It is at the top of the hour. I think we probably have a break now, right? Okay, so thank you. Thank you to our panelists. That was wonderful.
May I just make a comment? One block is very much important. We have to keep surveillance as a block with all the parameters we just discussed. So that is very much important to keep to invest in terms of surveillance, because the risk is once the pandemic has gone, and we hope as soon as the sooner the better, but then the surveillance should be in place, and there should be finance and trained human resources in technology, of course, but we should continue to speak about surveillance and to invest in surveillance. That I think is perhaps some obvious, but we have to remember to all of us that is very much important. Sorry.
Thank you.
Well chaired, Eric, keeping us under control.
involved in the sense of high-scale testing, PCR testing, and then lateral flows that could be done at home. And so actually we shouldn't underestimate the role that the increased public understanding of infectious disease and transmission has had on our ability to respond to future pandemics. And I just wanted to remind you of what that meant. If you were in the field of genomics or evolution, you would have been quite horrified. I was quite horrified by having the work that we were doing regularly on the front pages of The Sun, for example. I'll just give you some of the headlines from The Sun I found online. Horrific new COVID variant is most evolved ever. New COVID variant with 32 horrific mutations detected. Another new variant with 46 mutations detected in France. New COVID variant is most mutated so far. COVID super mutation may cause devastating new outbreak. COVID could mutate into ultimate strain 600 times more deadly. So, I could go on. There's pages of this stuff. As is common with these, no one kind of reflects back on these headlines and says, have we got this right? Have we got the balance right here? But to have the work that we did pretty much uninteresting to anyone, including our, close relatives 3 years ago to this, with the number of mutations and the type of mutations being listed in the Daily Mail. It's quite something. So the world has changed kind of, irreparably, I would say. So I said this session is about talking about new pathogens detection. I'm going to stop talking in a minute, but I want to just give a kind of a slight, and just to reflect on that quote from William Gibson, and just to think about metagenomics, which is a subject that's very close to my heart, and hopefully it will get picked up in a discussion. But just in terms of SARS-CoV-2, or what we used to call nCoV 2019, and before that we just called some cause of a novel pneumonia, unusual pneumonia in Wuhan in China. This is an example of science fiction, actually, because the first cases of COVID-19 are now recognized to have been around mid-December. There was a bit of uncertainty around those dates, but Michael Warraby, for example, did a great paper looking very, into a lot of detail into case histories. And he's pretty confident that the first symptom onsets of cases was around maybe the 14th, 15th, 16th of December 2019, and there weren't cases before there. Now, about 10 days later, a sample was sent to a Chinese commercial metagenomics diagnostic company called Visions. And they identified that new virus on the 26th of December. So that's about 10 days from the first known symptom onset of this new virus. So, you know, the dissemination of information from China has obviously been heavily criticized over the course of the pandemic. Let's just think about that. The first genome sequence from metagenomics, and that was replicated by several other labs. The first actual release sequence was from Yongzhen Zhang in Fudan University, and then followed quickly by the Chinese CDC sequences, came out on the 10th of January. But I think that's absolutely phenomenal, because that's about 20 days from, you know, symptom onset to a public domain genome. So say what you like, but that is amazing. Now, would we, in the UK, in Italy, anywhere in the world, be that quick at being able to identify a genuinely novel pathogen, characterize and release the data? I think that is an argument hopefully we can have in the discussion. Maybe we would be, maybe we'd be quicker. So, you know, I think, so the first question I'm going to ask of the panel to get us kicked off is along those lines, which is that after the experience of COVID-19, are we now better prepared for the next pandemic pathogen? Maybe we're worse off. But critically, and so you can answer that very quickly with a kind of better or worse or, you know, I don't know. But the question I want you to think about is what existing techniques that are actually, you know, exist, that we know how to do, that are unevenly distributed, either globally, as is often the case, or unevenly distributed between pathogens. Like we're good at looking at things in some ways for some pathogens, but not for others. What would you like to see put in place to help us tackle the next pandemic pathogen? And I've thrown them a curveball, because it's not the question that I said I was going to ask them, because we've kind of answered that one already. So I'm going to ask Mira to start, and I think if you could just very briefly introduce yourself, then answer the question, and then we'll go through.
Oh, sorry. Thank you very much, Mira Chand. I'm a microbiologist. I lead on emerging infections at UK Health Security Agency. I'm going to answer that not with just a better or worse prepared. I'm actually going to answer it with an example. So Susan alluded to this in her talk. A little earlier this year, we had an outbreak of undiagnosed hepatitis in children, for which we did not know the etiology, and we had to do fairly rapid work to be able to try and understand what pathogens were contributing to that, which are probably more than one pathogen. But in that, I think we found two things. One is that we could deploy metagenomics very quickly. We could bring data out from it. We could come to an answer. We could use that answer in the public health response. I am not, as a user of metagenomics before COVID, as that confident that we could have done that 3 years ago. So I think that we have had an improvement in capabilities there. And we were able to do that in more than one centre in the UK. But there were three things that I really needed to go alongside the metagenomics to get that outbreak investigation to work. One was sampling, the ability to have detailed clinical samples from a patient of the kind that we needed, even a vulnerable patient, even a critically unwell patient. One was analysis, complex analysis that linked the genomes with the epi and the clinical data and tried to make sense of what was happening. And the last thing was laboratory phenotypic virology, where I could test out what we thought was happening based on the genomes and understand if that was a possibility in real life. And those are the three capabilities that I would say are unevenly distributed. They are still challenging. They're challenging in every outbreak scenario we've done. But if you were to go and now replicate that somewhere with much more limited resources, those things can be very, very difficult. There is something, I think, developing that is uncomfortable, which is a sort of model where analysis is very centralized globally. So the model that we are not working towards, but maybe even falling into, is everybody generates data, it goes onto a platform, and then there are 2 or 3 places that have really built up analytic capability. And that's not right, because to understand your data, you are best placed to be in country, in the epi situation, understanding your outbreak, knowing everything that's going on, and with that full context. So we have to enable people to be able to analyze their data themselves, as well as bringing it into that global space. And I think, so those are the things that I would pull out that I think we really need to support developing all over the world.
Okay, brilliant. Antonia.
Yes, thank you very much. I'm Antonia Ricci. I am the Director General of Istituto Zooprofilattico Sperimentale delle Venezie. It's one of the 10 public veterinary laboratories in Italy. The one I'm heading is in the northeastern part of Italy. Then there is people here from other istituti zooprofilattici. We are a network of 10 different institutes, but we work closely together with nearly 100 diagnostic labs scattered in all provinces of Italy. So it's a really strong network with a very high diagnostic capability, and we perform institutional activity, control in animal health, in food safety, and in animal welfare, and a lot of research activity. I'm in management now. My background actually is not virology, so I will not really reply, I'm sorry, to your question. I think Alessio Lorusso from Istituto di Teramo is really much more able than me to reply to really technical questions. Thinking about new techniques that appeared during COVID, I think the One Health approach is a new technique, is a new way of working together. And I would like to give you some thoughts about the One Health concept. We have talked a lot about that since COVID appeared, but also before. It's not something new. But sometimes I think about One Health as an empty box. It's very popular, we all use it, we all look at it. You know how many conferences are titled the One Health approach, but I would like you to think together with me about what this really means. So when COVID started, in Italy, the Istituti Zooprofilattici, with all their people able to analyze samples, to do this kind of activity, were left at home. I was really desperate because with the lockdown period, I was leaving expert biotechnologists at home because we didn't receive samples, vet samples. We had nothing to do, and I was really mad on that. So I started calling. I also wrote a post on Facebook saying, please use the vet network. We are able to help. I mean, a PCR is the same. If you do it on avian influenza or on COVID, it's the same thing. But we took some time. At the beginning, we were completely neglected in this. So really, we were shouting. But then the situation was becoming worse in the human side, and it was clear that there was the need also of having other support, and so we were fully involved, and Alessio and other colleagues from Teramo know very well in analyzing swabs from patients, and then quite quickly, it became also apparent that we were able to do sequencing very well because we sequence animal pathogens always. We have also an approach which is targeted to population diagnosis, population epidemiology. So we were much more used than the human doctors to screen a high number of samples. So we never screen single samples, we always screen massive numbers, and it's the same thing we do with sequencing. So we were on board quite quickly, we did a lot of analysis, and people started talking about One Health. And they said, this is not One Health, this is just helping. This is not really our job. Usually we do something else, but there's a need, and we do this. Another sector in which we are involved, and again, Alessio knows much better than me, is all animal models. And that is very important also to study COVID and to study pathogenicity, to study virulence, transmissibility. So that's another sector in which we were involved very quickly, and we have really a very good collaboration in the One Health approach. But what is One Health from my point of view? One Health is really I think, to understand that animal health has an impact on human health. So it's not that we do things for the human health. We look after animal health because this is prevention toward human diseases. So what I think that we should really elaborate more is the importance of surveillance in the animal-human interface. We can prevent pandemics. I think we prevent many pandemics that really do not go on newspapers because they do not happen, doing animal health prevention, the prevention of animal diseases. But it is something that we should do in animal reservoirs where spillover events happen, which usually is not in our countries, is in developing countries. We were saying this also before, but I think it's crucial, and I don't see so much investment in this, really to work on veterinary cooperation, really to prevent this kind of phenomena, to look at spillover, to look at which viruses are in the wildlife, are in the animal reservoirs, and then orient surveillance in humans, being informed from what happens in the animal and wildlife reservoir. The last thing I would like to say, we work a lot in avian influenza. And I don't know, I hope in the UK you do that. But what we say, what I think is relevant is to perform surveillance in people exposed to avian influenza viruses, because that's an interface. That is something that could happen. So when we work on avian influenza outbreaks, it's not only to solve the animal health problem, but we should be much more careful about looking at the possible risk of spillover. As vets, we say this continuously, and I don't see a lot of activity from this point of view. So this was a little bit
thank you.
My point of view on One Health.
I might come up with it. I might have a follow-up question about One Health, but I think we have two more perspectives, veterinary perspectives, and then we might follow up on One Health a bit more. Keith.
Yes, thank you. I'm Keith Sumption, Chief Veterinary Officer, FAO, and it's extremely nice to be in this building because I've only been here twice before. That was because my children were graduating from school and they allowed this to happen. So it's nice to come for another reason. Yeah, FAO is one of the 4 international organizations as part of the quadripartite for One Health. We have teams supporting surveillance and largely driven by the avian flu risks over the last 15 years. We have teams in about 40 countries. So what's changed and what has the perspective that COVID has brought? Well, on one side, on the veterinary side, it's not as great as most countries as it is in Italy or in the UK. There isn't mass screening. There are very few samples coming into veterinary laboratories. And for zoonoses often don't cause any disease in the animal itself, so there's no reason for someone to submit those samples. So we've looked with amazement at how wastewater sampling is suddenly screening a whole human population, and then we look at the countries we work in, and there isn't maybe a sewage system that allows you to look at the population because there aren't those systems in place. But we look at the scale of what you've managed to sort of work on, and it's amazing, and we think, well, could we use some of that capacity for all the viral discovery? We've been dealing here where you talk about a pandemic. We have 3 going on in animal health at the moment. One is avian influenza in poultry, wild birds. Another one is African swine fever, wiping out pigs. And we have lumpy skin disease in cattle, which is a smallpox equivalent in cattle. So we've got all these things happening at the same time. What are the sort of changes that we might see that would begin to be triggered by the COVID? Well, one is in relation to the pandemic fund, the pandemic FIF as it's called. We're looking at what does integrated surveillance look like? What would be the game changer in terms of countries? Now, Italy is unusual, I think, But in most countries, you've got, the Ministry of Health, you've got agriculture or separate livestock, fisheries, environment. How do you get them to work together unless you've got a centralized way of funding? How much budget comes from the Ministry of Health for One Health? Almost nothing, probably zero in most countries. Italy might be different on that. So where is that contribution coming to the prevention side? And will the game changer be, for example, that we would expect to see an integrated budget covering both the prevention and the early detection in the human population, but also the earlier detection of the things that Antonio mentioned when they come into the animal population, whether or not they cause disease. So that's something that we have to see an investment in. Another is that essentially we need to offer a service now that makes a difference. So I was in Bangladesh last week. You try talking at a primary healthcare hospital about the next pandemic. They're dealing with everything at the moment. If you talk about rabies, they say, yeah, the vets aren't doing anything. So there's something there that you can already start to act as a early detection, disease, manage it, and it's a template for what might happen with a pandemic. So I think we've learned a lot, and there's maybe a little bit more respect about the need on the medical side to have the veterinarians and the animal health involved. Thank you.
Great. Alessio. Okay, it works. So the topic is huge. So, by the way, I'm Alessio. After two directors, it's going to be a small guy, or small, not very small. But anyway, I was supposed to be in Qatar. We were looking at the World Cup, but Italy didn't make through, so I sold my tickets. Anyway, I'm sorry, but England, we won the cup.
Sure.
Yeah, sure.
Well, it's nice of you to say so, but we knew that.
Anyway, sorry for the joke, but anyway, so the good point after the pandemic is that probably the people, the society got aware of the fact that most of the emerging infectious diseases of humans come from animals. That's something that was not really robust in the human population. Even my son would ask me, what's your job? I say, oh, well, I look for viruses of humans before they get to humans. I look for them in animals. So that what we need to do is implement our surveillance activities in animals. But where? As Antonia said, we need to work in those areas where we have a strong promiscuity between humans and animals. That's Africa, for instance. So my lab, my institute historically has been involved for decades in surveillance of animal disease in Africa. First of all, by educating people. So if we don't educate people there, they will never get knowledge about virus. And imagine genome sequences, it's very difficult to get trained on that. So we do that. We go there, we go even in the field there with our mini ion sequencers. We train them how to interpret the data, because the good point is how I interpreted those huge amount of sequence reads out of biological samples. For instance, okay, we stressed about the use of metagenomic, metatranscriptomics. We do that since, I think, 2011, Cesare. We got this magnificent journey into the metagenomic approach. We got several data out of animals. If you sequence a rat, if you sequence the gut content of a rat, you will find several viruses. And what? We need interpretation, we need animal work, we need biological work in high containment facility, because if we don't link that virus to a specific biological property, it's just sequence reads over there. And what we do with those sequence reads, we need a database. We need a shared database with the physicians. We need to share our discoveries with the society. That's the point. Still, we don't have that. I'll make an example of how much I care, how much we care about surveillance. So usually vets work with strictly animal disease, as Dr. Sampson said, and with zoonosis. So for instance, my lab has been involved for several decades into a disease, an infectious disease of sheep and cattle, which is caused by a virus which is called blue tongue. We know everything about blue tongue, and we know that comes from Northern Africa. We know that. Every year we have incursions to Europe of this virus. We know that But it's not only blue tongue. There are other viruses. One is called epizootic disease virus. And so we went there in Africa. We are good friends with African people, in Tunisia mostly. And we know about the virus since like 2 years ago, okay? We got everything now. We got the genome, we got the biological properties, we got everything. And we said, look, the virus is coming. Last month, we received a call, and the virus was in Sardinia, the same spots where we had the first BTV incursion 20 years ago. So we do a lot of surveillance. That's why we need to sublimate those surveillance by by producing data which are useful for the society. Otherwise, it will be just something for papers or just for academic trials. But we need to produce data which improve the society. That's the point. So integrating, as Keith Sampson said, the surveillance between animal disease and human disease, and those viruses that we do not know, it's important, but basically we need also to link the virus we discover in animals to specific biological properties by using infection models or in lab models like ex vivo explants, organoids. So there is a guy in our lab which is very good on that. So that's why we need to train people to do that. Otherwise, we are not prepared for the next pandemic because, okay, we cannot prevent the next pandemic. We can get knowledge about the virus because it's difficult to prevent a pandemic, but we can get as much as we can knowledge about that virus. That's the point.
Thank you. Lots to think about there. Patrick.
Hi, yeah, to try and keep it brief. So I'm Patrick McClure from the University of Nottingham. Maybe another step down the ladder, as I'm still a senior research fellow and often, well, most of the time still at the bench with a pipette in hand. So just something from that perspective really was that, going back to the very first case in Wuhan, that I believe the sample sent for metagenomic sequencing was actually identified by pan-coronavirus PCR. So I think that was a key point I wanted to make, that's a very simple technique, often followed up with another very old technique, Sanger sequencing, that to try and thin out which samples are submitted for metagenomic sequencing, and also something that can really be deployed very widely regionally around countries and around the world as well, because I think most regional diagnostic labs do not run these sort of PCRs, and it can put a lot of pressure on referral centres and reference labs around the country. So that's something that I would how do you get closer and closer to the B of the bang? And I think there's still a place for the humble PCR, particularly for pan-genus and pan-family assays.
Yeah, because SARS-2 wasn't a completely unknown virus, was it? It was a distant relative of a relatively well-characterised virus.
And that's why the team in Wuhan thought, when everything else was negative with a standard panel that would be run in Italy or the UK, when you've exhausted that first take, using your clinical and research knowledge, what do you go to next?
Yeah, and I think we often think about, we worry about missing the complete unknown unknowns, but actually in reality it's unusual. It's something that's related to something that we know about, and as you say, there are often cheap assays to find such a thing, and so I guess you're proposing a relatively low-tech solution that might get you to the answer quickly.
Because when we've got in our panel, standard diagnostic panel, we've got 4 seasonal coronaviruses usually, so we've got 2 alphas and 2 betas, so we know these have become endemic 4 times in the past. Or we look at the paramyxo family, where we've got parainfluenzas, we've got metapneumovirus, we've got RSV, as well as measles and mumps. We kind of know that that this type of virus can make the jump and sustain it in the human population. Then we've got some inside knowledge already on what to be ready to go for.
Okay, yeah, I mean, so you've mentioned a relatively a technology is well available, molecular diagnostics, and we've also heard about metagenomics. I guess I'd like to follow up with the One Health perspective a little bit. I don't know whether we want to think more about COVID or we want to think about the next thing, but One Health, as you said, Antonio, is one of these quite difficult to get your head around terms. But if we think about it very specifically, maybe all the panelists could quickly answer this, or if we don't want to, we can move on. But it's where we should be sampling and what we should be doing when we're sampling, and what our sampling frame looks like. This is what Eric and Christoph worry about. Because obviously we've all heard about these very high ticket price ideas of we just do metagenomic sequencing of all the animals in the world, and we'll just find all the viral sequences that are out there, and we'll put it into some AI and it will tell us the next pandemic pathogen. I think most of us think that is a fanciful idea at the moment, at least. But nevertheless, that's got quite a lot of traction, that idea. The idea we should just be sequencing a lot more animals directly. Some people would say we need to focus that down on the animal-human interface, where there's close connections between, where zoonotic pathogens are likely to spill over from, like live animal markets in China, for example. And some people would say, and maybe I might be in this camp, is you shouldn't worry about the animals particularly, just look for clusters of sick patients and go and find out what they've got. So would you like to kind of react to that? Maybe we'll take the One Health perspective first, but then all the panelists. What should we be sampling? Where should we be doing it? And could we have detected the coronavirus earlier if we'd had a One Health surveillance strategy set up? Whoever wants to speak, I don't.
Can I say something?
Yes.
So, sorry. Yes. So SARS-CoV-2, yes, is a member of a species which was well known already. The species is SARS-related coronavirus, and if you look at the ICTV, there is pending for designation members of this species. Okay, so it was not unknown. People were aware of this virus since 2007, 2008. Those family. Think about that. We know everything about bats, and we say that 40% of the bat virome is composed by coronavirus because of NGS. But this was because in 2003 and 2004 we got the SARS-CoV-1. And the first coronavirus which was discovered in bats is from 2005. It was not even a SARS-related coronavirus. So everything we know about coronavirus is like 16 years old. So it's not that much, and there's still enough to work there. So what I want to say is that we need to sequence and we need to focus our attention on bats and SARS and MERS-related coronaviruses, I think, and in avian influenza. Those are the viruses which are defined by several papers in the literature. If you look at papers from 2006, 2007, they were calling these viruses a biological bomb ready to explode. So we knew that, but we didn't have an outcome in terms of prototype of vaccines to be ready for this specific viral species, and that's it. So that's why sometimes I ask myself, so why do we do a lot of surveillance if we do not have a private company, because private company can do that produce prototype of vaccines that, in case of emergence, can be used to stop, at the early stage, an infection in animals and in humans.
Okay, I think Mira would like to jump in, then maybe Keith might, or Antonia.
Is that on?
Yeah.
Yeah. So I'll come back on one thing you said, we're looking for sick patients. It's late. We know it's late. It's a good safety net. Can't stop looking, but we don't want to go at that stage. I wanted to say something, but also to ask you this question. So I think about 50% of this table is working on avian flu right now, and what we're responding to in avian flu is a change. So there is a normal state for avian flu. It's quite well understood actually what it is and its path through migration and so on. And we've seen a change in epidemiology, and now in human health we understand you've had a change, and we are responding to that by risk assessing what is happening. I don't think that process of the sort of we've had a change in the animal epidemiology or something about the animal disease, and that move through to, okay, human health, you now need to gear up. I don't think that that's always that well connected, and I'm not sure, and this is my question to you, how well in other animal diseases that normal state is characterized so that we can understand when we are in an unusual situation, because I think the precursor of the human problem will be something changes in the animals. It's just, how do we pull that out and make a signal that we can respond to?
Yeah, that's why, that's why sequencing and discovering reads and viruses is just a part of the work. So that's why we need to have labs that can work in high containment facility, test the virus immediately. Sometimes, I mean, I would say that I don't care. So if I want to test the pathogenesis of the kinetics of infection of an animal, in animal model in the lab, getting the permission, the authorization to do that is pretty long. I mean, so if we have an emergence and we have to immediately infect animals to assess the pathogenesis, then assess the length of the viremia, assess the onset of antibodies. I mean, how long it takes, it takes time. So that's why sometimes we need to say, okay, we have an emergence, we need to go straight into animals because we need to, because this could be a public health emergence. That's why we need to characterize biologically what we do observe by genome sequencing. And still, there's a lot to do on this.
Okay, I think Keith might want to come back on the surveillance question a bit.
Well, first I'd like to say I really support what Alessio said. I mean, the UK and Italy have got world-leading reference centres for animal disease diagnosis, where they're doing the animal transmission experiments and the pathogenicity. That's incredibly vital. Many labs have simply become PCR labs. Not being able to do that pathogenicity, biological characterization, it's huge. So my plea would be, if it can come out of this meeting, if it can be maintained, but keep these resources suitably funded and supported. It was incredibly difficult 2 years ago to get any money for SARS-CoV-2 work in animals. And we were getting all the questions all the time about that area. But to go back to your point, Mira, brilliant that you brought up avian influenza, because there's this kind of linear thinking now that says everything is going to come from a bat through directly, or it's going to come into an intermediate host, and then we're forgetting that we've got circulating viruses that could and are evolving. We don't quite understand the combination of the control measures we use in the animal populations, the wildlife dynamics, the interplay. There's a real potential we can make things worse by the way we control things. So maybe the COVID evolution, development people could actually help us a lot. So what are you learning about the pressure from vaccination and other measures and the evolution of COVID? And can that help us thinking about whether vaccinating against avian flu is going to be, in some situations, more dangerous or not? So I think we may lose sight of the current risks for circulating in animals. But to go back to your question, can we just get everything sequenced out there? Well, in 2008, there was a new epidemic in the animal population of Europe, complete shock. It was a vector-borne disease, and there were no sequences except bits of segments were on the database. That's because the animal's genomics, the viral genomics, is so poor. We've got so little out there from vector-borne diseases and the way that they evolve. We have been working on this side with avian flu. We have, for example, used many places avian flu is not reported. So we used sampling in live bird markets to see trends and see what the changes are, and then be able to do something. So bringing in this sort of environmental sampling into monitoring trends, I think that's vital. And the new technologies will help us to do that. But being able to understand biologically something about what we're dealing with, that's what Alessio said, we have to invest in some of those key experiments as well.
Okay, thank you. Did the audience want to make any comments or questions about One Health or anything to hear? Oh yeah, we're going to get the microphone so that people can hear. Also online, I think.
The challenge for One Health, in my opinion, is the fact that we still dissect it by sector, and we don't deal with it as a collective thing. And I find it shocking. I remember, Nick, you and I were in California about 10 years ago when they were launching their biodiversity genome program, where massive funding went to look through the world, to look at biodiversity of what life is. And nobody batted an eye that we needed to know what the diversity of the creatures on Earth, and now they're digging in the ground and looking at what diversity had changed over the last 1,000 years. And we are still, as you rightly said, have a very, very poor picture of what is the circulating viral biome that we live with and interact with. And there might be an opportunity now to turn the challenge and say, for us to be able to dissect what's happening, check the impact on health, is for a major initiative similar to that program that we were at, and everybody was talking about understanding what it is. So my appeal is maybe we should start to push that One Health is not analyzing sector, and that viral genome is a massive gap in our collective knowledge.
Yeah, very good point, thank you. I think we're going to move on to the second major question, and that's the last question, don't worry. The Ferrero Rocher is being stacked. And this is a question I did actually ask you, so no surprises. And I guess the idea here is to capture some of this, because there's no point just talking about this amongst ourselves. Capture this and actually do something about it. And it feels, Keith, a bit like one of the things that's coming up is funding, but also about siloed funding. That feels like one of the things we need to start to think about in terms of we're all asking the same questions, maybe of different systems, but is there a better way that this kind of work can be funded? Because obviously clinical and animal infections are closely related, human clinical. So the question is, what novel capabilities or strengthened capability should we be putting in place to help our ability either to discover, detect, and maybe, Alice's point, characterize future pandemic threats? And just to mix it up a bit, let's start at the other end and work this way. So over to you, Patrick.
I'll put me on the spot there, but
yeah, there you go.
Well, I mean, I think building on my point earlier, there's there's a lot of basic techniques which are just not disseminated broadly enough. So I think what the COG UK network showed, for once we know what we've got, there's a huge amount of capability from many different disciplines that can feed into this sort of greater effort. But I'd like to see we've shown what we can do, but that's now somewhat receding, I think. So I think sort of, a similar network in diagnostic and veterinary labs, but with that kind of, broader diagnostic capacity, because I think there's just too many negative samples passing through labs, passing through hospital labs, I guess through veterinary labs, all the time, and they're right there. The material is there, but
So what's your pitch to a funder then? Exactly, what do you want to do?
Well, I would like to see. I think initially it would take a reference lab or someone to put together a extended diagnostic resource, whether that is many amplicons targeting hundreds of viruses on to put through Oxford Nanopore, but then to see that in diagnostic labs around the country as a second line of diagnostics, I think would be great, because I think a lot of the labs around the country it's very plug and play. So there's some sort of de-skilling, and also there's a lot of the R&D departments in hospitals. They're there, but they don't have the time to really put these new technologies in place. So, my pitch would be to come up with a new, much broader diagnostic that, leaned on these new technologies, but, potentially covered disease X in many viral families, and then to get that installed around, I can think around the UK certainly, but then of course around the world as well.
Okay, so a kind of high throughput, low cost diagnostic with sequencing that will do all the viruses that we're interested in. Yeah,
we don't need whole genomes initially. We can go to metagenomics once we've identified that. But yeah, we need to get better at identifying, the very first cases, or just to get this up and running, keep ourselves match fit. I think really we've shown we can do it, but we could be sequencing common cold viruses a lot more, and people could be learning their skills on sequencing those. But we could also be routinely saying, right, severely ill patient, severely ill animal, first line negative. What do we go to next? Let's have a look and see if we can pick something else up.
Okay, great, thank you. Alessia.
And so we discussed this with Cesare, which is the head of our reference lab for genomic sequencing. How do we do diagnostics in the future? We were discussing this, we discuss this every day actually. So what we do is we test our samples coming from syndromic surveillance in animals, from local vets. We have several panels for respiratory disease of cats, dogs, whatever. It comes often that those samples are negative, so then we test them with metagenomic, and sometimes we got results. For instance, once we had a cattle with suppurative encephalitis, and the cattle was positive for astrovirus, which is a well-known pathogen for encephalitis in cattle. We knew that, but we didn't have the test yet. But after that, we implemented our test. So diagnostics is not that easy. It's a combination of several techniques, PCR, NGS, and, for instance, what I stress my people to use also is RNA-scope to stain the RNA straight in the tissues. An example, we got 2 horses died by severe pneumonia. Those horses got sequence reads in the lungs of a strictly related Culex virus, alpha mesoni virus. So we are staining now the RNA straight in the lungs, because if we got a positive staining of its RNA in the lungs, then we have an association, probably, that virus, which is a strictly related Culex virus, caused the pneumonia in horses. So it's not that easy to come to a consensus. Anyway, last point, we need to train people in low-income countries to use such technologies. If you look at the sequence coming from Africa about SARS-CoV-2, about human respiratory syncytial virus, because we have a project with our Tunisian partners in the hospitals, it's extremely low. So we don't have any knowledge about circulation of several viral pathogens in low-income countries.
Great, thank you. That's great. Keith.
Well, I think we need several things, and almost at the same time. I mean, we're still struck by how seeing data from ICUs that don't have a method to very, very quickly screen. So we clearly need that. We need something for population level screening fast. And that doesn't always mean wastewater, but it might in many situations. It can also mean aggregation points for animals, markets, and abattoirs, for example. So that's another one. And we need a joint risk assessment approach, which actually says, within this country, so each country almost really has got to have its risk assessment about those points where it's going to pick up something and be able to put them in the special measures, and which can include nanopores and so on. But they may be in very targeted locations because of the risks that have been identified.
Thank you. Antonia.
Yes, as I said before, and as colleagues remarked, I think capacity building in low-income countries is fundamental, really to go there where, as I said, the human interface, the human-animal interface really happens. You were asking before where we would do surveillance. I think surveillance should be done in the wildlife, in those situations in which the risk of contact with humans is high, which is, not so frequent because wildlife should remain separated from humans, but actually this doesn't happen always. And surveillance in people exposed to massive animal outbreaks. Also slaughterhouses, surveillance of people working in slaughterhouses could be another target. But we really have to work where these phenomena are much more frequent than in our realities.
Thank you. Mira.
I actually think everything's been said, so I'm going to be pretty short now. Just round up and saying, as I completely support actually everything that's just been said, and I think we need all of those pieces, and we need also to concentrate on that last piece, which you alluded to in risk assessment, which is how those things come together into actionable intelligence, and what that intelligence is, and what things we might do at different levels, because we often are in the position of having to do that in a very live way with new data in new circumstances. And I think developing those analyses at the same time might make us more agile in future.
Okay, well, I feel like yes, Keith, sorry. I'm going to respond.
Not to respond as much as something I'd forgotten to say, but I wish I'd said it earlier. For some of the animal infections that we've worked on, we've taken 30, 40 years to understand the aerosol biology of how they get from the upper respiratory tract, spread over sometimes kilometers, and are picked up. The minimum infectious dose of an aerosol. What size of the particle is important? How long in certain humidities does it transmit? Now, the technologies for looking at particle size and their infectivity, that seems to be a technology that we almost should be having a science around that's better. There's something that's new, saying with this spectrum of particle sizes, we would expect those to reach the lung, we'd expect them to reach different tissues, so we can predict the transmissibility, the need for masks from this. So, correct me if I'm wrong.
So Christoph addressed this actually. So you need to give all your pigs and horses iPhones, and that will help with the app determine the transmissibility. Well, you could track them with something, not an iPhone, but something high-tech.
This wasn't tracking. This is simply if you look at the particles coming out of the mouth. So I think there's a really interesting study in Ireland where they looked at abattoirs because there were so many COVID cases. What did they find? Wet, cool conditions, fantastic for particles, and 1 air change an hour. So you had this marvelous conditions that they worked out for transmission. So how do we get fast within a matter of days to pick up that transmissibility? I'd like Mira, tell us.
If only we knew. I think actually we have been having this discussion thanks Nick, sorry I'm very bad at remembering. We have been having this discussion very recently, we came to the conclusion that was an animal model question, and I'm interested in whether you think that's correct. We thought about different scenarios where we could attempt real-life assessment of those things, and we thought all of them would be too challenging and too full of confounders for us to understand, but I'm interested if that's the conclusion others have come to.
Would anyone in the audience like to pick up on that, or anything that's been said in this section, or would like to make a case for any other capabilities we haven't mentioned? Yeah, Peter. Yeah, go for it.
Thank you. When we've spoken to numerous stakeholders, so our remit is delivering training and building capacity primarily in the global south, looking at Latin America, Africa and Asia. And over numerous engagements, I think initially we spoke to, at least 25, 40 scientists in 25 countries across those regions. We've done global surveys, we've spoken to numerous networks ongoing throughout the programme, and the overwhelming thing that those people in those countries are asking for in terms of training is bioinformatics. And I thought, just wanted to mention that because it tied back to what Mira said almost in the first comment of this session. I'm sure we'll talk about more in our working group tomorrow, but I just wanted to share that really. That's, obviously people requesting training and talking about capacity building and all the elements of genomic surveillance, but overwhelmingly it is bioinformatics. I don't know if you want to add anything to that, Leah. I don't want to put you on the spot a bit. But yeah, it's just a really interesting outcome. I think we'd just kind of like to share that with everyone in the room at the moment.
Yeah, training seems to be vitally important, and we need. It seems. Do we all agree that the capability needs to be equally distributed for it to be effective? Because the next pandemic pathogen can come from anywhere, and it's going to need to be analysed and recognised locally for this system to really work. I think that's, I'm seeing nods, so I think that we're generally agreed on that.
As we look into that, do we need to be prepared by commitment from 3-4 major sequencing countries of the world that says we will have a proportion of our resources until that capacity is coming, where we would accept samples to come in, to start preparing people rather than have a gap?
Yeah, I mean, that's an interesting point. I mean, one thing, thinking about William Gibson again, sequencing is one of those technologies that has become much more evenly distributed recently, and we can do it in country, but I think one of the analysis gaps that was mentioned by one of the panelists is the bioinformatics analysis and data analysis, which does, I think Mira said, it does tend to get centralized, and that's probably not the way forward, but I think sequencing is one of the ones we're in the best shape with, it feels like, but I think we in the UK and Italy can do more, right? I mean, to help, for sure. Yeah, thank you.
In terms of the bioinformatics training, I think one of the things is that when you're thinking about the need to build networks as well as building capability, you can integrate the two, right? So you can do the training that builds the capacity in the country, and then also builds a professional network of people that will work together. So, and that's quite critical. And just in terms of the sequencing point, I actually think you need to get the sequencing in country, because to have something as a sort of a sustainable system, you want it to be end to end. You don't want to have to be, shipping samples 5,000 miles away and then putting the data back. What you want is you want everything to be done as quickly as possible, ideally as locally as possible. And so actually, that capability building. I don't think you just take bioinformatics on its own. I think you need to get the end-to-end process. And I think as well, one of the things where we're quite good in the UK, for example, is things like our clinical scientist training and our specialist training within the NHS. And again, it's thinking about how can we take what we do and what we've got, which we're quite good at, and how can we then make that available elsewhere and provide the training to allow people not just to do sequencing in an African country in response to a pandemic, but actually to be able to do that and provide a clinical service which then improves health outcomes in that place as well. And so I agree, the training is critical, but I think it actually offers some other opportunities beyond just building capability in one place.
Yeah.
Thanks, Tom. We've got a few reactions here.
And for this, I guess that the role of international organization is critical. So WHO, the World for Animal Health Organization, the former OIE, I didn't get the name yet in my mind, WOA, and the FAO. So we've been training people in Africa, in Ethiopia, in Tunisia, in Eastern Europe several times, but sometimes they just do the training with us and there's not sustainability. So there's not long-lasting activities. So they keep writing to us and say, we have sequenced, we need to sequence those samples. Can you do for us? Say, yes, but we train you to do that. But they say, oh, it's difficult to get reagents. That's the first, claim they do. We don't have reagents. So that's why we can talk a lot about this, but then reality is, maybe Keith Sumption can say something about that.
Yeah, thanks. I think we've spent years shipping samples with all the difficulties to Padova and the reference centers in Italy, and they do a fantastic job. But the work involved in getting the samples shipped is incredible. So I would never want to sort of, I would really like our colleagues here to help with the bioinformatics and not have to receive until it's necessary. That would be one side. So I think what colleagues in some of the countries, low resource countries, have said, it's not our limitation to do a nanopore or to do give us bandwidth, give us satellite coverage so we can send the information up to get it analyzed. So stop telling us that it's our lack of. So to answer your question,
Starlink.
Pooled procurement might be one of the answers. Mm-hmm. So the idea that you have a budget for so much capacity provided at a country level, and it will go some of it to the Ministry of Health, some of it to the animal health targets for the amount that you would use it, when you would use it. That would generate, I think, and the budget for that might be something that, let's say, wouldn't be huge, and it might be something which is worth investing in continuously afterwards to give that basic capacity.
Thanks. I think, Mira, you might get the last word here.
I think I'm all right, actually.
Are you sure? You just got your light on. I thought that you were going to say something profound.
Sorry, I can try if you want to. It'll be more profound.
Okay, right. Well, so I think we're going to start to wrap up. I recognise these faces as ones that desperately want a cocktail. And I'm in the same boat. No, so I would say that the panel has failed. What the task I set them. I set them very explicit instructions, was to have a big argument today and to have lots of dissent. But actually everyone's agreed with each other. So it's very disappointing. I have to sum up, which is, I don't want to spend a lot of time summing up because I think we've just talked about it and you can remember what we said. But it sounds like we've got good agreement that we need much better capacity. That capacity needs to be globally distributed. We need to think about the One Health and the animal and the animal-human interface much more. We need metagenomics technology, we need better molecular diagnostics, we need much better data analysis. No one really made a case for wastewater, which I thought was interesting. I thought maybe someone would say we need a lot more wastewater. And Keith's kind of up for a bit of wastewater, but not a great amount. And so I think that's been great. That has been a success. It's good that we've all agreed, actually. And I think hopefully there's enough here. Lee is going to capture some of these in the working groups tomorrow, and hopefully we've got enough to say where the funding priorities are, what we should be thinking about next, and how we get ourselves better prepared for the next pandemic pathogen. So I'd like to thank the panel for their contribution and you for your contribution. And I think that in the programme we're gonna just stop it there. It feels right to stop it there. We did have another 2 hours scheduled. We had another 2 panels for you, but we're going to just go straight to cocktails. So, thank you very much.